لا 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 لا. ها؟ Hello, guys. Good evening. Sorry, good morning. No, good afternoon. Okay. Good afternoon. Can you see? Can you hear me? Good afternoon. Good afternoon. So, I hope your preparation is on the right track. You're doing well. I hope everything is sorted. Can you send us the empty PDF? People who are in home will write in tabs. Okay, I'll send you the PDF. I am uploading the empty PDF on the Telegram group. You from there. Uploaded, guys. You can pick from the Telegram group. Okay, can we start? Can we start? So let's not waste any further time. Let's kickstart the discussion. We'll start with the rapid revision. See, I rather than trying to write it down, I will send you the PDF. I want you to be available here. We'll try to do a brainstorming activity. I want you to be actively involved. I want you to be available with every single point that we discussed. Sir, is this PDF enough for surgery? Question. It is more than enough. It's your last minute resort. इसके आगे कुछ नहीं देखना है. If you have time, revise your notes. Otherwise, nothing beyond it. Sir, I know FTR है, लेकिन थोड़ा serious. Yeah, guys, don't worry. We revise. You revise along with me. Let's kickstart the discussion quickly. Talking about currently when we talk about drains, जो available है. So drains are devices which are going to take out the collections are divided into two categories. One we call it as the open drain system. Another one is the closed drain system. The closed drain system is going to be divided further into two components. One which is going to have a passive drainage. Another one is going to be an active drainage. Itna yaad rakh lena whenever we talk about it. There is a lag. There is a lag. Too much lag, too much lag. Acha, एक second. I am in the institute only. Give me a second. Hold on for a second. All right, guys. So I've tried connecting it to a different network. Let's see again. Let me know if there is a lag or not. Okay. So As we talk about drains, one of the exam questions is going to be in terms of your image base is going to be drains. Drains are categorized into two categories, open drains and closed drain system. Open drain and closed drain system का एक ही difference है that the open drain will not have a bag or a conduit to collect. Closed system will always have a collecting unit. That's the simple one. ठीक है. When we say passive collection, the passive collection is because of two forces. Either it is because of a dependent force, which we call it as gravity, or it is because of capillary gradient. So when I say capillary gradient, it is basically nothing but difference in pressure और कुछ नहीं है. Active pressure का मतलब होता है it is going to be using an active pressure which is nothing but a negative suction pressure. It is a negative pressure is used to pull the secretions out. ठीक है. Now, your job is to identify whatever drains I'm going to show you. Let's have a quick component. Now, what is drain number one? Quick feedback. What is this drain number one? Guys, agar thoda bahut manageable, it is fine. Let's not get into that because more important is your time. I don't want you to waste your time at all. Right, very good. The first is not, see, when we talk about the orange color, yellow color, any of these colors, when you say these are going to be, material is going to be latex. Okay. Now, because you can see there's no collecting unit in it, this is going to be an open drain system. So this is what we call it as the corrugated. It's called as the corrugated rubber or a corrugated latex drain. Now, itna yaad rakh lena, agar if I ask you a simple question that whenever you're putting anything in the body, do you want it to be biologically inert or biologically reactive? Quick feedback. If you're putting any drain in the body, do you want it to be biologically inert or do you want it to be biologically reactive? Yes, you're correct. We need inert. Remember, silicon is inert, latex is reactive. So now we have moved away from the silicon. Now we are going into we have moved away from the latex. Now we're going to silicon. So the second drain that you can see here, it is your silicon drain. It is your silicon corrugated drain. Telling you it is biologically inert. You see the green line that is present right in the center. What is a green line? Quick feedback. What is a green line that corrugated drain? The green line in the corrugated drain is a radio opaque line. It is a radio opaque line. Now, reason for having a radio opaque line is whenever you're going to remove this drain, sometimes if a part of a drain is broken and left inside the body and you're suspecting the drain is not completely out, take an X-ray, you will find that radio opaque line telling you there's a residual component that is present. Now, what is the drain number 3? Now, this is nothing but everybody knows it. It is going to be your Foley's catheter. This is going to be your Foley's catheter, right? Now, in the Foley's catheter, the tip of the Foley's catheter is what we call it as the eye of the Foley's catheter. Then you see the area where you have a balloon, that is nothing but the balloon of the Foley's catheter. Whichever the color component is there, it is your balloon inflating channel. It is for balloon inflating. Through this, you're going to inflate the balloon. This is the urine collecting channel. This is for urine collection. Now, question is when you're going to inflate the balloon, what are you going to use what are you going to use in order to inflate the balloon in the Foley's catheter? क्या use करेंगे? Quick feedback. Balloon को inflate करने के लिए Foley's catheter में क्या use करोगे? Yes, distilled. Absolutely, very good, guys. Very good. You're in a right track. We are going to use distilled water. Now, why are we not going to use air? Because it is going to float up. You will not be able to drain the urine. Why are you not using any crystalloid? All crystalloids will form a crystalline forms, which is going to form crystals, and that crystals are going to occlude the channel. While deflating, you will not be able to deflate the Foley's catheter properly. So, purane exam, your previous exam question was, if you are unable to deflate, Foley's catheter, if you are unable to deflate the Foley's catheter, how do you approach this patient? So let's say there's a Foley's catheter. Very good, beta. Who is that? Stuti Sahu. Beautiful. Correct. Absolutely correct. It is going to be USG guided puncture. It is going to be USG guided puncture of balloon. That is how you are going to deflate the Foley's catheter. Absolutely correct. Now, image number 4, this is an extended version of the Foley's catheter. This is what we call it as the three-ways Foley's catheter. Now, in a three-way Foley catheter, this is basically for bladder irrigation. This is basically for a bladder irrigation. So whenever you've done any bladder surgery, prostatic surgery, urethral surgery, for the rinsing or in terms of cleansing it, or in order to do a bladder wash or a bladder irrigation, three ways is used. Again, you see the color code will be your balloon inflating channel, right? This is your balloon inflating channel through which you're going to inflate the balloon. This is how the urine is going to flow. So this is your urine collecting channel, and this is how the how are you able to identify the widest? So सबसे मोटा है, the biggest among the three will be for urine, and the smaller one is going to be for irrigation. The smaller one is going to be for irrigation. This is for irrigation, right? So this is about your three-ways Foley's catheter. Now, what is this? So image number 5. Guys, this is your previous exam question in NEET PG. They have asked you, what is image number 5? Very good, Garima. It is your Penrose drain. This is the example of a Penrose drain. What is image number 6? Quick feedback. Kya hai image number 6? This char chand laga lo. This is going to be an important exam question. Yes, yes. Very good, guys. Very good. It is not Potovac, it is Romovac, beta. Changed. It is a Romovac drain. Now, two important questions about Romovac drain. Is it an open system drain or a closed system drain? You can see there is a bag that is there for the collection. So it is going to be a closed system drain. Now, is it going to be active or a passive drain? You can see all these components which are there. No, this entire drain, if you compress it, it will create a negative pressure in suction. So it is a active drainage system. So this is going to use the negative pressure to cause the collection, as simple as that. Now, this is again image number 7. This is going to be T-tube. Now, T-tube is used for your CBD. Either you're doing for CBD surgery, it is used for CBD stone clearance. So whenever the CBD exploration is done, CBD surgery is done, if you're removing a CBD stone, for all these T-tube is going to be used because it's a transparent material. It is made up of silicon. It is made up of silicon. Okay. Yes, you can do investigation that your T-tube cholangiogram can also be performed. Now, what is your image number 8? Image number 8. Image number 8. You can see this is a nice roll up here. So it is nothing but pigtail catheter. This is your pigtail catheter. This is going to be your pigtail catheter that is going to be used for drainage of abscesses in solid organs. Image number 9, again a repeat exam question. This is nothing but your nasogastric tube, or also referred to as the Ryle's tube. My question to you is, what is the length of the Ryle's tube? How much is the length of the Ryle's tube? Very good, beta. The approximately is 100 centimeters. Somebody is asking about DJ stent also. Remember, pigtail catheter, DJ stent mein na differentiate kaise karoge? Now, in a pigtail catheter, you see only one end is turning up. In a DJ, you will see that you will have both the ends turned up, right? So if you have coiling on both ends, coiling of both ends is going to be called as DJ stent. We will use DJ stent in your urethral surgery. So these are the fenestrations which are present in the DJ stent. And one of the greatest advantage of DJ stent is it is going to have fenestration throughout its tube. It is going to have fenestration throughout its tube. Okay, so this is your DJ stent, which is going to be your pig. So how do you differentiate pigtail and DJ? Pigtail will have only one end coiled. The DJ will have both the ends are going to be coiled. Okay. Now, when you talk about the Ryle's tube, a previous exam question they asked you is on the nasogastric tube. How do you measure the adequate length of the nasogastric tube to be inserted? We have a rule which is called as Nex rule to identify the exact length that is required. So you take this as a representation of the patient. let's say this is the ear that is present, this is the neck, this is the thorax. Let's say this is the suprasternal notch, this happens to be xiphisternum. So the next rule says, measure the distance from the tip of the nose to the tip of the earlobe, from there to the xiphisternum. Nose, earlobe, and xiphisternum. Whatever is the length that you get, this is how you are going to measure the adequate length of the nasogastric tube to be inserted. And that is what we call it as next rule. Everybody knows it. Okay. Question number 10 was your previous NEET PG question. This was also your previous exam question. This is what we call it as the Jackson. This is what we call it as the Jackson-Pratt drain. Now, again, it has got a bulb. You squeeze it, it creates a negative pressure. The bulb is going to collect all the secretions which are present. So this is also an example of closed system draining via negative pressure. It is an active component that is present. Another one that you have, image number 11, this is what we call it as the Sangaskin-Blakemore tube. I hope everybody knows that Sangaskin-Blakemore tube is used to control the bleeding in bleeding esophageal varices, right? So this is used to control bleeding from esophageal varices. It is used to control bleeding from the esophageal varices. It is from the esophageal varices, right? Now, right. So when you're going to look at this, there are two balloons which are present. This is what we call it as the esophageal balloon. This happens to be your esophageal balloon, and this happens to be your gastric balloon. Now, the previous exam question that they asked you is that what do you use to inflate these balloons? Is it going to be water, air? Is it going to be crystalloids? What are you going to use? Remember, the objective of having this Sangaskin-Blakemore tube is to have a compression at the G junction. So you take this as a representation of the esophagus and the stomach. And let's say this is the SBT tube that you have placed. I want, when the balloon is inflated, I want the balloon to stay here. At the same time, I want the gastric balloon to stay here. Now, if you inflate with fluid, the balloons are going to become heavy, they will sink down, and the pressure will not be exerted where it is required. So in order to prevent any mishap, I am only going to inflate with air. So both the balloons are inflated with air. Maximum, they'll ask you how much is the quantity. Remember, esophageal balloon is inflated to a 40 millimeters of mercury pressure. Gastric balloon is inflated with 300 ml of air. That's the maximum capacity that we are going to look across. Okay. So these are the various drains that are going to be important from the exam perspective. Clear? So far, any doubts? Is the speed okay? Quick feedback. Speed ठीक है? कोई शक, कोई सवाल? Perfect. Okay. Achha, one more thing. I will be giving you the PDF, so don't worry about it. I will upload immediately after the lecture, so there will be no lag. You will be ready to go and read, right? Okay. Beta, everything सब बताऊंगा, कोई tension नहीं लेना किसी के लिए. See, I don't want you to get ahead of your time. I just want you to understand that whatever I'm going to teach you is going to be the most important, precise points. अगर मेरे साथ आपने revise कर लिया ना, you don't need to, look across beyond anything of that size. I just want you to be precisely available. Whatever we are trying to tell you, it is more than enough. Okay? Chalo. Beta, this is more than enough. You are not going to look for surgery per se. I'm telling you, जो session आज आप मेरा attend कर रहे हो, there is nothing beyond this. This is more than enough. इसके आगे किसी की जरूरत नहीं है. ठीक है? चलो. Now, color codings of the sizes of the cannulas are important. So quickly देख लेते हैं. हमारे पास orange. So the first cannula that you have is going to be an orange cannula. It is going to be a 14 gauge with a flow rate of 240 ml per minute. This is the widest bore available. The second one that you have is a gray cannula, a 16 gauge at a flow rate of 180 ml per minute. इसके बाद आपका आता है green cannula. The green is going to be 18 gauge with a flow rate of 90 ml per minute. इसके बाद आता है आपका पिंक कैनुला विच इज गोइंग टू बी अ 20 गेज विद अ फ्लो रेट ऑफ 60 ml per minute. Then you have a blue cannula. The blue cannula is going to be 22 gauge with a flow rate of 35 ml per minute. Then we're going into pediatric one. We have the yellow cannula which is present, which is going to be a 24 gauge at a flow rate of 20 ml per minute. And the last one that you have is your violet cannula, which are 26 gauge with a flow rate of 12 ml per minute. Okay. Now, all these cannulas color codes are more important with the size. Flow rate is also important. Exam के लिए कौन-कौन से flow rate आपको याद रखने हैं? That is what I'm going to tell you. Remember, सबसे पहला orange का flow rate याद रखोगे, green का flow rate याद रखोगे और blue का याद रखोगे. Right? So the three standard flow rates that you have to remember: orange, green, and blue. इतना याद रख लो. That is more than enough. Rest everything will be sorted. Now, how do you remember the color code? For that, we have a very simple mnemonic. देखिए, द कोर ऑफ द अर्थ इज मेड अप ऑफ लावा. लावा जो है वो ऑरेंज कलर का होता है. लावा के ऊपर सॉइल है, सॉइल ग्रे कलर की है. ग्रे कलर के सॉइल के ऊपर हमारे पास ब्यूटीफुल ग्रीन ट्रीज है. ऑन टॉप ऑफ दिस ग्रीन ट्रीज यू हैव ब्यूटीफुल पिंक फ्लावर्स दैट आर प्रेजेंट. ऑन टॉप ऑफ दिस ब्यूटीफुल पिंक फ्लावर्स यू हैव द ब्लू स्काई व्हिच इज प्रेजेंट हियर. राइट, सो दिस इज द ब्लू स्काई. और स्काई में क्या है, दिल्ली में बहुत ज्यादा देखने को मिलेगा, and that is going to be your yellow sun. The sun is precisely present here, which is shining bright and quite. उसके बाद आपका violet है. The violet is going to be universe. ठीक है, तो sun के ऊपर मतलब आप मान लो कि ऊपर क्या है, आपका universe है. अगर आपको यूनिवर्स में फील नहीं आ रही ना, तो आपके फील के लिए थोड़े से स्टार्स बना देते हैं. सो दिस इज गोइंग टू बी योर यूनिवर्स. तो याद कैसे रखोगे? Orange is 14 gauge, gray 16 gauge, green 18 gauge, pink 20 gauge, sky 22 gauge, sun is 24/7, 24 gauge, purple is going to be 26 gauge, right? Clear? इतना याद रखना. ऑरेंज का जो है दैट इज गोइंग टू बी 240. कैसे याद रखोगे? 14 गेज है, 14 में 240. ठीक है, 44244014. ठीक है, 4 मिलेगा, 4 का मिलेगा 240 में मिलेगा. 14 is 240. ठीक है, करेक्ट ना. इसके बाद आता है आपका फोलिस कैथेटर का. अगर आपको थोड़ी लाइफ डिफिकल्ट करनी है, थोड़ा स्पेस आपको ऊपर मिल जाएगा. फोलिस कैथेटर के जो कलर कोड्स है ये भी याद रख लेते हैं. फोलिस कैथेटर के जो कलर कोड है, it is going to be remembered in the same size. Remember, the standard mnemonic that you have is going to be Gori very beautiful. जो गोरी है, she is very beautiful. Needless to tell you, no. So G is your green catheter, the green Foley's catheter. It is going to be 14 French in size. It is going to be 14 French in size. O is going to be orange. Orange is going to be 16 French. R is going to be red. Red is going to be your 18 French. Y is your yellow. Y is your yellow. Yellow is going to be 20 French. V stands for violet. Violet is going to be 22 French. And B stands for blue catheter, which is your 24 French. Which is going to be 24 French, right? So Gori is very beautiful. I know Kale are even more beautiful. I'm not racist. I'm not going to tell you in that sort. For the exam only, this is how you to remember. Now, what is a French? Now, French jo hai, you take this as the catheter. Okay? This is the lumen of the catheter, and this is how the lumen of the catheter is looking across. Now, there are two diameters. This is what we call it as the inner diameter of the catheter, and this is what we call it as the outer diameter of the catheter. Now, when we say French, French responds to as the outer diameter of catheter. आपके guide book में outer circumference दिया हुआ, that is wrong. ठीक है, it is going to be your outer diameter of the catheter is what we call it as French. ठीक है, इतना याद रख लिया. नंबर गेम इससे ज्यादा जरूरत नहीं है. क्लियर? ठीक है, चलो, we are coming to that beta. Okay, somebody is asking about drain removal periods also. वो भी quickly देख लेते हैं. You have a space here. So quickly talking about the drain removal period. to talk about the drain removal period. कब drain निकालोगे? Now, if you have put a drain for a thyroid surgery, I hope everybody knows thyroid surgery में हम drain डालते हैं to look for reactionary hemorrhage. So if there is no bleed after 24 hours, you can go ahead and remove a thyroid drain. For all your breast surgeries like mastectomies, it should be removed after the 5th post-operative day, right? If you have done for any bowel anastomosis, after a bowel anastomosis, see, normally we put the drain for to look for any anastomotic leak. That is going to be after the 4th post-operative day. If there is no leak after the fourth post-operative day, you can go ahead and remove the drain as well. In breast, we are keeping it to look for seroma collection. Now, if you are going to put a drain for like a T-tube you have put, right? A T-tube will only be removed after 10 to 14 days for a tag to get matured. Only then I'll be able to remove the drain. If you have put a drain for an infective collection, if you have put a drain for the infective collection, so the criteria to remove the drain, which is only once the drain clears up. Once the drain clears out. Once the drain clears out, then only you'll remove it. If ICD is put for pneumothorax, if ICD is put for pneumothorax, there are two criteria. One, there is presence of lung expansion on X-ray. Presence of lung expansion on X-ray with absence of column movement. With the absence of column movement, once the column of the ICD stops moving, that is when you're going to remove. Okay. So these are the various drain removal period. अच्छा, removal में एक और आपके लिए एग्जाम में क्या आता है? That is going to be your suture removal periods. ठीक है. तो drain removal period everybody knows it. अभी बात कर लेते हैं suture removal period की. So we're talking about the suture removal period. ड्रेन रिमूवल हो गया, सुचर रिमूवल पीरियड. तो कौन सा सुचर कब रिमूव करोगे? ठीक है. नाउ इफ यू आर टॉकिंग अबाउट सुचर रिमूवल पीरियड, if the suture is placed on the face, it has to be removed at the earliest, that is 3rd to 5th day. I am going to remove the suture. So 3 to 5 days के बीच में you have to remove the suture. If you have put the suture on the scalp, on a scalp, it is going to be 7 to 10 days. What are the other components we remove 7 to 10 days? It is going to be your arms. So arms में suture डालोगे, that is also going to be 7 to 10 days. Then you have trunk. If you put the suture on the trunk, then I'm going to wait for 10 to 14 days. Trunk में suture removal is done after 10 to 14 days. Apart from trunk, when you talk about the legs, for legs also it is going to be 10 to 14 days. Then you have hand and feet. For hand and feet also it is going to be 10 to 14 days. So trunk, legs, hand and feet, it is going to be 10 to 14 days. सबसे ज्यादा आपका palms and soles पे होगा. Palms and soles will take 14 to 21 days. It is going to be 14 to 21 days. ठीक है. Now, usually I'll give you a cartoon to remember this. So if you talk about, let's say this is the face, right? So this happens to be the trunk of the patient. Let's say this happens to be the lower limb, which is here. Let's say this is the upper limb that you have, and this is the palm that is present. Okay. So we say suture removal period. If it is on the face, if it is on the face, I will remove between 3 to 5 days, right? If it is on the scalp, it is going to be 7 to 10 days. On the that is on the trunk, on the arm, and as well as on the legs. These are going to be anywhere between. So I use a different color code. Let's say this, which are using green. If you have put the sutures on the trunk, you have put on the arm, you have put on the legs, it is going to be 10 to 14 days. So arms is 7 to 10. Sorry, small correction. So scalp is 7 to 10. Scalp is 7 to 10. Arms is also going to be 7 to 10. Arms are also going to be 7 to 10. So this is going to be 7 to 10 days. So arms are also going to be 7 to small screw up here. 7 to 10 days. Scalp arm is also 7 to 10 days. Then you have trunk. You have the trunk, which is going to be anywhere between 10 to 14. Legs are going to be 10 to 14. The hand and the feet, right? The hand, which is going to be, and the feet, which is going to be at this. So when we talk about the difference between the hands and feet, it is going to be in the below the level of elbow, which is your hand and feet. It is going to be at the level. So you have on the back of the hand, it is on the same context. Okay. So these are going to be anywhere between 10 to 14 days. Remember, palms and soles, palms and soles. These are going to be 14 to 21 days. Okay. The components are very important. The table is there. Okay, fine. You can fill it up, but I wanted every data to be at one place so that you can quickly revise it. And this is the context of revision. ठीक है? हो गया, trains खत्म हो गए, cameras खत्म हो गए, laparoscopy के instruments देख लेते हैं फटाफट, ठीक है? Now this bigger instrument is what we call it as a 10 millimeter port. इस port के अंदर you will put a 10 millimeter trocar. Trocar is going to have a sharp tip. This is going to be a hollow structure. This is a 5 millimeter port. छोटा port है. And a 5 millimeter trocar. ठीक है? So port जो होता है hollow होता है, trocar solid होता है, port और trocar together you insert in the abdominal wall. You remove the trocar, leaving the port behind for your instrumental access. लेकिन problem क्या है? Trocar is always sharp. So the sharp trocar can cause injury. To prevent injury, you have a blunt tip trocar. Now, a blunt tip trocar is what we call it as an atraumatic trocar. This is what we call it as the atraumatic trocar. And we all know that the atraumatic trocar will be seen as the Hansen's port. So ये वाला image याद रख लेना Hansen's port का. It is an atraumatic trocar. This was asked previous exam. Now this another instrument that you have. This is what we call it as SILS. SILS stands for single incision. This stands for single incision laparoscopic port surgery. It is a single incision laparoscopic port surgery. That means through one single access, you can gain 4 different instruments. So एक hole से 4 instruments. It is called as cells, right? Now this is what we call it as lens. Remember, the most commonly used lens is going to be 30 degrees, which is going to give you a wide viewing angle. So when you say what is a 30-degree angle is this angle that you're able to see. This is what we call it as a 30-degree viewing angle. So it is going to give you a very wide caliber because this opens up the entire view. So you'll have a very wide. So this is the viewing segment. No, so you can see how wide the viewing is. So lens is going to be 30 degrees. Your previous exam question is this. अगर laparoscopy में कोई एक instrument पूछना है, वो ये instrument होगा. इस instrument का नाम क्या है? What is the name of this instrument? Quick feedback, guys. Very good, beta. This is what we call it as the Veress needle. This is what we call it as the Veress needle. Now, Veress needle का 2 question पूछ लेगा. What is the size of the Veress needle? Remember, it is 14 gauge. And what is the diameter of the Veress needle? Remember, it is going to be 2 millimeters on the outer diameter. The diameter of the Veress needle is going to be 2 millimeters. It is a 14 gauge needle. Okay. Now the question is, what is it used for? Remember, it is used to create pneumoperitoneum. It is used to create pneumoperitoneum. That is to fill the abdomen with gas. So what is the most common gas used for pneumoperitoneum to be created? That is carbon dioxide. What should be the intra-abdominal pressure during laparoscopic surgery? That is 12 to 15 millimeters of mercury. What is the angle between the needle and the skin? That is Veress needle and skin during the entry point. Not only here, everywhere else, the angle will be 90 degrees. Remember, it is going to be pointing towards pelvis while incision. It will be pointing towards pelvis. So जब insert कर रहे हो, you will direct the needle towards the pelvis, not towards the xiphisternum. So it is pointing towards the pelvis during insertion. During insertion. Okay. So this is about the Veress needle. Now, if there is an accidental injury to a vessel or a bowel in a Veress needle, what are you going to do for an accidental injury? for an accidental injury by a Veress needle. I am not going to remove the Veress needle. Keep the needle in position. Keep the needle in position and convert to open. And convert to open surgery to identify the source from where it is bleeding. Okay. Every single point in Veress needle is your exam question. Sorted? Clear है? ठीक है? Can you move on? Guys, I want you to be active on the chat box. वरना पता कैसे चलेगा भाई? I want you to be available there. Just give me feedback. You're okay, not okay, understood, not understood. बस ठीक है? Continue to go so. Now, I've given you 4 images. यही images आपके एग्जाम में भी आएंगे in terms of energy devices या monopolar. Monopolar का मतलब है single pole होगा. Bipolar में there are 2 elemental poles which are present, harmonic scalpel and thunderbeat. देखो हार्मोनिक स्कैल्पल और थंडरबीट को डिफरेंशिएट कैसे करोगे? हार्मोनिक स्कैल्पल और थंडरबीट में 2 बटन्स देखने को मिलेंगे. हार्मोनिक स्कैल्पल विल नॉट हैव एनी बटन. क्लियर है? ठीक है. थंडरबीट में आपको 2 बटन देखने को मिलेगा, हार्मोनिक स्कैल्पल में कोई बटन नहीं देखने को मिलेगा. तो कैसे काम करते हैं? हाउ डज इट वर्क? मोनोपोलर वर्क्स ऑन द प्रिंसिपल ऑफ इलेक्ट्रिकल एनर्जी. Bipolar also works on the principle of electrical energy. Harmonic works on the vibrating energy. It works on the principle of vibrating energy created by sonic waves. It vibrates at a frequency of 20,000 to 50,000 hertz. It causes cut or coagulating effect on the basis of protein denaturation. It works on a principle of protein denaturation. Thunderbeat is called as the combined energy source. It is called as the combined energy source. That means it is a combination of both electrical as well as vibrating energy. It uses both electrical as well as vibrating energy, right? Now, when they ask you which of the following has the ability to cut as well as coagulate, remember all these. Now, Thunderbeat का जो second generation है, that can also help in cut and coagulate. So second generation. So this is in second generation of the Thunderbeat that can be able to cut and coagulate. First generation it was only able to coagulate but not able to cut. Okay. Now, how do you differentiate? Which is the safest energy source in a patient with pacemaker? A patient with pacemaker undergoes surgery. What is the safest energy device? Absolutely correct, guys. Spot on. Remember, it is the harmonic scalpel, which is considered to be the safest energy device. It is safest energy device for patients with pacemaker. Because it does not create any electrical impulses, so it will not interfere with the calibration of the pacemaker. Hence, it is considered to be the safest energy device for a patient who is having a pacemaker, as simple as that. फिर आपसे पूछ लेगा, how do you differentiate between a cut current? How do you differentiate between a cut current and a coagulating current? How do you differentiate between a cut current and a coagulating current? Now, this is your exam question. They've asked you multiple times differentiation between the cut and the coagulating current. In order to differentiate, you have to plot a graph between the voltage and the frequency at which the current is going to run. So on the y-axis, you have voltage. On the x-axis, you're going to have frequency. This is voltage. This is going to be frequency. For a cut current, you will see there is going to be low voltage, but very high frequency for cutting. In a coagulating current, you have high voltage, but you have low frequency, right? So this is how you differentiate between the cut and the coagulating current. In a cut current, it is going to have high frequency. It is going to have high frequency, but low voltage. On the other hand, for a coagulating current, it is going to be associated with high voltage associated with low frequency. It is high voltage with low frequency. ठीक है? Clear? So this is about your energy devices. इसके आगे एक point भी नहीं पढ़ना है. Clear है? बात सीधी है? ठीक है? Guys, I am repeating again. All that I want you to have is a little bit of faith. थोड़ा भरोसा कर लो. लास्ट मिनट रिवीजन के लिए इससे बेटर हमारे पास मटेरियल नहीं है. ठीक है? I'm not saying it is out of arrogance. I'm talking about with pure humbleness, because the material that I've compiled is a collection of all the previous year questions, topics and high yielding component. ठीक है? So don't worry about it. जब मैं बोल रहा हूँ इतना है तो इतना ही है. You don't need to go any beyond that. चलो, let's go with the suturing route. Now, ये आपके previous exam questions है. Quickly answer कर दो. Let's go across. What should be length of the suture material to suture a wound? It should be a minimum 4 times the entire length of the wound. It is a 4 times the entire, or a 4 times the length of wound. That is, should be, if the wound is 10 centimeters, the length required to suture that wound is going to be 40 centimeters. The depth of the wound, it is going to determine entry and exit of bite. It is the entry and exit of bite. That means the depth will tell you where do you want to enter and where do you want to exit. X is the depth of the wound, right? Distance between the two sutures should be twice the depth of the wound. The angle between the needle and the skin has to be 90 degrees, right? So angle is going to be 90 degrees. Distance between two sutures should be twice the depth of the wound. It should be twice the depth of wound. A suture ear is a suture that is left behind after cutting a suture. It should be a minimum of 1 to 2 millimeters, so that to avoid the suture from slipping away or the knot from slipping away. This is how you're going to look across here. फिर बारी आती है suturing technique की. Again, a simple one. This is what we call it as a simple continuous running suture. This is your simple continuous running suture. This happens to be your simple interrupted suture. This happens to be your simple interrupted suture. Now, when you look at this particular suture, you have 2 bites on the either end, but you need to analyze that how the suture's orientation is. Now, this is the wound and this is the suture line. They're perpendicular to each other. So this is what we call it as the vertical mattress suture. This is your vertical mattress suture. Now you see the suture line and the wound line are parallel to each other. So this is what we call it as the horizontal mattress sutures. This is your horizontal mattress sutures. If that is running in the dermo-epidermo junction of the skin, not getting onto the surface, it is what we call it as subcuticular sutures. Now, it is not subcutaneous, it is subcuticular sutures. Remember, this is the best cosmetic outcome. Suture with the best cosmetic outcome. Suture with the best cosmetic outcome is going to be your subcuticular sutures. So you have the simple continuous running suture, simple interrupted suture, vertical mattress sutures, horizontal mattress sutures, and the subcuticular sutures. All these are the various suturing techniques that are going to be present. But a harmonic scalpel, that is what I'm telling you, the new generation harmonic scalpel have the ability to cut and coagulate both. Thunderbeat also, the second generation, has the both ability to cut and coagulate. This is the update from your 28th edition of Bailey. I have mentioned in my recent classes also that the new gen, the current harmonic old wala available nahi hai. Current generation harmonic scalpel is going to have both ability to cut and coagulate. Okay? So do not go up on that. Chale? So knotting techniques. Knotting techniques, we know this is what we call it as a half hitch. A half hitch is a single loop, right? Whereas this is what we call it as the granny's knot. Granny's knot is an example of an unstable knot. It is an example of an unstable knot. This is what we call it as a reef or a square knot. This is what we call it as a reef or a square knot. This is an example of a stable knot. This is an example of a stable knot. And the last one that you have is your surgeon's knot. It is a surgeon's knot, and this is considered to be the most stable knot. This is considered to be the most stable knot. Now, सवाल ये है कि how do you differentiate between grannies and a reef knot, because they both are very, very similar. So all that you have to understand that when you look at the grannies knot, you see red thread here is going above the green loop, but on the other end it is going under. तो एक थ्रेड जो है वो ऊपर से जा रहा है, एक नीचे से जा रहा है. यहाँ पे भी देख लो, ग्रीन थ्रेड इज गोइंग ओवर द लूप, हियर द ग्रीन थ्रेड इज गोइंग अंडर द लूप. सो अगर एक थ्रेड ऊपर और एक थ्रेड नीचे से, ठीक है, ऊपर नीचे, इट इज गोइंग टू बी ग्रैनीज. लेकिन when you look across here, you see both the red threads here in the either direction, it is going below the loop, and here you see the green thread is going above the loop on either direction. So दोनों ही ऊपर या दोनों ही नीचे से, it is what we call it as reef or a square knot. Surgeon's knot के लिए ना, अच्छा एक छोटा सा करेक्शन है, दिस इज द सर्जन्स नॉट. ठीक है, तो सर्जन्स नॉट में, और एल्स टू मेक इट बेटर, थोड़ा टू मेक इट मोर सेंसिबल, लाइक दिस. ठीक है, हाँ, सर्जन्स नॉट में भी स्क्वायरिंग वाला रूल होगा. दैट मींस दोनों ऊपर या दोनों नीचे से जाएंगे, लेकिन इतना याद रख लेना टू रिमेंबर दैट देयर आर वन लूप हियर, टू. सो दो लूप नीचे, वन लूप ऑन टॉप, टू लूप्स बॉटम, one loop on top, and again you will have the same phenomena. You see red thread is going under the green loop here also. Here also you will see that the red thread is going under the green loop. Here you see the green loop is going over the red thread, and here also same. So either both down or both up. ठीक है. In the exam, they will highlight this on different colors, or they will give a very distinctive image जहां आपको clearly पता चल रहा है कि thread ऊपर से जा रहा है कि नीचे से जा रहा है. ठीक है, so don't worry about it. These are the 4 components. हमने suture removal period already बात कर रखी है. Quick recap. Face के लिए क्या है? Face आप बताओ, already हम लोग पढ़ लिया ना. Face के लिए कब निकालोगे? It is going to be 3 to 5 days. Scalp के लिए कब निकालोगे और arms के लिए कब निकालोगे? For both of them, it is going to be 7 to 10 days. Trunks, legs, hand and feet is going to be 10 to 14 days. Palms and soles is going to be 14 to 21 days. खत्म कहानी. ठीक है, इससे ज्यादा कुछ नहीं है. क्लियर? 3 ही डेट्स याद रखने हैं. फेस पे 3 to 5, स्कैल्प और आर्म के लिए 7 to 10. So you put it like the 7 to 10. Trunk, legs, hand and feet के लिए 10 to 14. Palms and soles 14 to 21 days. ठीक है, that is about your suture removal period. Coming to one of the most repeatedly asked question, last 2 नीट के सेशन में रिपीट हुआ है, आपके एग्जाम में एक बार रिपीट हुआ है. देन यू हैव एन INICT pressure ulcers, or also called as bed sores or decubitus ulcer. Currently, what is the criteria? The criteria is very simple. If the pressure exerted over an area is more than the capillary occlusive pressure. If it is more than that of the capillary occlusive pressure. See, capillary occlusive pressure simply with that, it is the pressure required to occlude the capillaries so that the blood flow to that area of the skin becomes extremely low. And somebody is giving me a very good answer. The capillary occlusive pressure is more than or equal to 30 millimeters of mercury. When the pressure exerted is more than or equal to 30 millimeters of mercury, this will result in pressure ulcer. When I say risk factor, it is because of prolonged immobilization. It is your prolonged immobilization. If not this, it is your chronic bedridden status. It is your chronic bedridden status or a chronic wheelchair bound status. It is a chronic wheelchair bound status. All these are associated with development of pressure ulcers. Now, what is the most common site? It can cause bit of prolonged immobilization can cause DVT. Pressure ulcers will not cause DVT. So what is the most common site? What is the most common? Very good. Garima, absolutely correct, beta. The most common site is going to be ischium, if not greater trochanter, if not sacrum. You remember this. These are more than enough. ठीक है, अगर ये भी नहीं है, इसके आगे heel, then you have malleus. Malleus में इतना याद रख लेना, it is the lateral more than medial. और last में अगर बात करनी है, that is going to be your occiput. That's it. Now, how do you do the grading of the ulcers? Very, very simple. You see this one. This is your non-blanching erythema. Erythema का मतलब होता है redness. ठीक है, when you exert pressure, no, it should blanch away, that means redness should disappear. Presence of non-blanching erythema indicates ecchymosis, that is grade 1. Grade 2, you can see there is partial thickness skin loss. So there is partial thickness skin loss, that is going to be grade 2. Grade 3, the subcutaneous fat is exposed. It is a full thickness skin loss. It is going to be a full thickness skin loss. And the last one you can see there is involvement of tendon in a muscle. So if there is involvement of underlying structure, if there is involvement of underlying structure, if there is involvement of underlying structure, it is called as grade 4. And the reason that you have is US. US stands for unstageable. It stands for unstageable. It indicates presence of necrosis or slough on an ulcer. So you cannot assess the true depth of the ulcer. So hence it is considered to be as unstageable. Now remember, for your grade 1 and grade 2, it is going to be conservative management. In a conservative management, I'll give water or an air bed, frequent change in position. We'll give a frequent change in position. So when I say frequent change in position, remember, in the frequent change of position, we cater across here that if the patient is bedridden, so every second hourly, and if patient is a wheelchair bound, so in every 10 minutes, ask the patient to shift the position for 10 seconds. Okay? 10 minutes, 10 second rule. That is correct. And proper skin care. A proper skin care is required. Whereas the other grades that you have, your grade 3, grade 4, and unstageable, it requires number 1, cleaning and debridement and application of vacuum assisted closure called as negative pressure wound closure system. VAC has a pressure of minus 125 millimeters of mercury plus conservative protocol. Plus your conservative protocol that we have just discussed. Okay. So it is going to be water or an airbed, frequent change in position. Skincare has to be continued there as well. And this is how you're going to mention your pressure ulcer. Pressure ulcer में sites important है, grading important है, grading के साथ management is also important. When you do a see VAC का advantage क्या? Daily dressing की जरूरत नहीं है. VAC जब आप लगाओगे, you have to do dressing. So it is going to help for 4 to 5 days. So you will change VAC only after 4 to 5 days. So dressing will only be changed after 4 to 5 days. VAC का advantage ये है कि daily dressings are not required if you're putting a VAC. ठीक है? Clear? Okay. But when we talk about the varicose vein, I'll tell you the difference between the arterial and venous ulcer. Don't worry. VAC is costly, right? Okay. In terms of burns, okay, 2 questions that you commonly ask is, what is the most common rule for assessment? Most common rule for percentage of body surface area burnt assessment. So when we say most common, then it is going to be your Wallace rule. That is the rule of 9. But if I change the question to the best rule for percentage of body surface area assessment, it is going to be Lund and Broder's chart. This is going to be your Lund and Broder's chart. Okay. Now, we all know Lund and Broder's chart is going to be extensive, so we'll be going with the Wallace rule. Now, Wallace rule में इतना याद रखना, adult में it is the head and neck, which is 9%. बच्चों में head and neck, बच्चों में the head and neck is going to be 18%. बाकी सब कुछ ठीक है. Adult में lower limb is 18%. But adult में lower limb is 18%. Child में lower limb is going to be 14%. Adult में perineum 1% है. बच्चों में पेरिनियम नहीं होता है. दैट इज द ओनली डिफरेंस. बाकी सब कुछ सेम है. ठीक है. सो डू नॉट ट्राई टू बी स्मार्ट. सो इतना याद रखो क्या अलग है. अडल्ट में हेड एंड नेक इज गोइंग टू अकाउंट फॉर 9%. हियर इट इज अकाउंटिंग फॉर 18%. लोअर लिम्ब अडल्ट में 18% है, बच्चे में 14% है. दैट्स इट. This is your carry home message that you have to remember. Now, percentage in terms of depth, again, this table is going to be important. आपसे एग्जाम में जब भी सवाल पूछा है, they've given you a burn, they've asked you to identify the depth of the burn according to the description. Now, in the first degree burns, remember, it is only involvement of epidermis. It is only involvement of epidermis. Whereas secondary superficial, there is involvement of papillary dermis. Whereas in secondary deep, there is involvement of reticular dermis as well. And your third degree burn, it is your full thickness burns. It is your full thickness burns. Fourth degree, there is involvement of underlying structure. There is involvement of underlying structure. There is involvement of underlying structure. Now, जहां पे skin नहीं होगा, वहां पे दर्द नहीं होगा, तो you know the skin is present. So first degree is extremely painful. Second degree is superficial, extremely painful. There is no pain here, but there is something called as presence of pin prick sensation. There is an intact pin prick sensation. Third degree skin nahi hai, no pain. Fourth degree no skin, no pain at all. But a head and neck, both anterior posterior together is 9% in adults. No change in that. Blisters are the characteristics of secondary superficial. So first degree may or may not have. Secondary will have it. Again, secondary may or may not have. No skin, no blisters. So in third and fourth degree, there will be no blisters at all. The color here is going to be presence of erythema in first degrees. This is going to be your bright red in color. This is going to be, that is secondary deep, is mottled pink, or also called as the pale waxy white in color. Now this is going to be leathery in appearance, and this is like a charcoal burn. Fourth degree is charred appearance. Now, first degree, second degree, superficial, deep will heal. The third and fourth will not heal. There will be no scar in first degree, second is superficial. Rest, all of them will leave the scar behind. Eschar is a form of fibrotic scar. So hence, eschars are more commonly seen in these particular areas. Okay. You remember this table, that is going to be more than enough. Clear? So far, any doubts, quick feedback? ठीक है बेटा, the plan is to complete the entire workbook so that you can go read and revise it. अगर ज़्यादा खिंच रहा है, if you want me to take tomorrow evening also, we can do that as well. I am totally up to your convenience. If you are able to bear the entire workbook, we'll continue off. If you say कि रात को 7-8 बजे के बाद you feel a bit more tired, you want to revise, you want to read by yourself, we can continue tomorrow evening, whatever is left out. So don't worry about it. ठीक है? चलो. Okay. So how do we resuscitate? Remember the current fluid of choice that we have. The fluid of choice for burns resuscitation. The fluid of choice for the resuscitation of burn is going to be Ringer lactate. Parkland is an old formula. We do not use it any longer. So currently we are using an ATLS formula. ATLS formula may, if there is a second or a third degree burn, and if the patient is an adult, then it is going to be 2 ml per kg per percentage of total body surface area burn. If it is a child, then it is going to be 3 ml per kg per percentage of total body surface area burn. If it is a fourth degree or an electric burn, we are least bothered whether it's a child or an adult. It is going to be 4 ml per kg per percentage of total body surface area burn. You will remember these formulas, right? Now, the protocol for administration. The protocol for administration. Now, the protocol for administration is quite simple. Now, I'll give you an example. I have a 70 kilogram patient with 30% of the total body surface area burn, which is going to be a fourth degree burn. How do you calculate and how do you resuscitate this patient? The component is very simple. Because of 4 degree, it is 4 ml per kg per percentage of body surface area burnt. It will come down to as 8,400 ml. This is what we call it as the burn fluid. Now, whatever burn fluid that you have calculated, I will divide them exactly into half. So you have 4,200 ml as one half, 4,200 ml as the second half. The first half will be given as fast IV within 8 hours. So first half is given within 8 hours. The second half will be given as slow IV, but within next 16 hours. But the rule is that the entire burn fluid must be given within the first 24 hours. That's it. Okay. So burn fluid should be given within 24 hours. This should be administered within the 24 hours of resuscitation. So that is the carry-home message for you. So burn fluid should be administered within 24 hours of resuscitation. And that's the single best important component to be followed. Now, the most commonly used colloid as of today in terms of burns is going to be human albumin solution. It is the human albumin solution, which is commonly called as the HAS solution. Ideal time to administer is after 24 hours. That is once you've done a primary resuscitation. How do you calculate it? It's 0.5 into weight in kilograms. Into percentage of total body surface area burnt, right? If you consider our patient, that is 70 kilogram patient, so 0.5 into weight in kilograms into percentage of body surface area burnt. So this will give rise to as 1,050 ml. This will come down to as 1,050 ml. That is called as one portion. So whatever you have calculated, we call it as one portion. So how do you administer? We will divide on a 12-hourly basis. So when you start administering the first 12 hours, it is divided into equal 4 hours. So the first 4 hour, the second 4 hour, and the third 4 hour, you will see you will be giving one portion in the first 4 hour, another portion, so another portion. So the first 12 hours, I will give 3 portions. In the second 12 hour, I will divide them into 6 hour and 6 hourly. So in that, I'll give another one portion each. So in the next 12 hours, I'll give only one portion. From here onwards, I will give every 12 hourly one portion. So that is what we have. So for the first 12 hours, I will give 3 portions. Second 12 hours, I'll give 2 portions. And here onwards, I'll give one portion, that all, right? So this is how you are going to administer the colloids. I hope everybody is clear. Okay. So how do you manage? We have the important components of the topical agent. Remember, the most commonly used topical agent is your silver sulfadiazine. The small correction here, this is your silver sulfadiazine with cerium nitrate. This is considered to be the best topical agent. So best topical agent is silver sulfadiazine with the cerium nitrate. Remember, your silver sulfadiazine is extremely effective over Pseudomonas and gram-negative bacteria. The disadvantage is that the silver sulfadiazine cannot penetrate eschar. It cannot penetrate eschar, so it will become useless if the eschar is formed. There is no specific side effect. Whereas silver nitrate, again, it is effective against Pseudomonas as well as gram-negative. But here the important point is, again, this can also not penetrate eschar. The side effect is it results in blackening of skin. So because of poor cosmetic outcome, this is withdrawn. It is not available. Mefenide acetate, on the other hand, it has got little against the Pseudomonas or gram-negative. But the only advantage is it can penetrate eschar. But the important side effect, while applying it, it causes excessive amount of pain. It becomes unbearable. Patient starts to cry. And as rightly said, it also causes metabolic acidosis. It also results in metabolic acidosis, right? Silver sulfadiazine with cerium nitrate, it is extremely effective against Pseudomonas gram-negative. It can penetrate eschar as well, and there is no side effect. Hence, it is considered to be the best topical agent that there is available. Right now, couple of important exam questions. Number one, what is the most common immediate cause of death in a patient of burns? The most common immediate cause of death in burns. The answer immediate means as soon. Yes, absolutely correct. It is going to be asphyxia. It is going to be asphyxia. If it is not in the option, the next best answer is the neurogenic shock. It is going to be the neurogenic shock. So it is asphyxia. If not, then it is going to be your neurogenic shock. If I say what is the most common early cause of death? Early cause of death in burns. For an early cause of death, yes, absolutely correct. It is your hypovolemic shock. It is going to be your hypovolemic shock. What is the most common late cause of death? The answer is going to be sepsis. Absolutely correct. The answer is going to be sepsis. If I say what is the most common overall cause of death? The overall cause of death in a patient of burns, it is again going to be sepsis, right? What is the most common stress ulcer? The most common stress ulcer in burn that you will notice, it is what we call it as the curling ulcer. This is what we call it as the curling ulcer that is going to be in the stomach, right? Achha, what is the most common organism to cause burn wound infection? Most common organism to cause the burn wound infection. The most common organism to cause a burn wound infection, it is, as rightly said, it is Pseudomonas. Now, because you are able to give me all the answers, give me the last one. What is the most common malignancy in a burn wound? Most common malignancy in burn wound, it is going to be your low-grade squamous cell carcinoma. It is your low-grade squamous cell carcinoma of the skin. And this low-grade squamous cell carcinoma of the skin is commonly referred to as the Marjolin's ulcer. How do you identify Marjolin's ulcer? How do you identify Marjolin's ulcer? Characteristic of Marjolin's ulcer. Now, when you look at the ulcer, if this is the ulcer that is formed, you would see the edge of the ulcer that is present. It is going to be raised and everted. The edge is going to be raised and everted. So you see the edge is going to be everted. Okay? So this is how you know it is a Marjolin's ulcer. You see the edge of the ulcer. Edge is going to be raised and everted. Again, this is your exam question. How do you identify a Marjolin's ulcer? Yes, it is going to be raised and everted. Absolutely correct, Chandra. Beautiful. Good. Now you're on the right track. Okay. So all these are previous exam question, and this is all that you need to know in the context of burns, right? बेटा फोटो में देखने के लिए ना एज देखो उठा है और पीछे की तरफ जा रहा है. अगर आप एज के अराउंड का स्किन नहीं देख पा रहे हो, इट इज रेज्ड एंड इवर्टेड. एज सिंपल एज दैट. ठीक है, क्लियर? चलो, now we'll talk about the hyperparathyroidism. Now we have three different types of hyperparathyroidism. We have the primary, we have the secondary, or the tertiary. Primary is because of increase in secretion because of a neoplastic disorder. Secondary is because of chronic hypocalcemia. Tertiary is because of reactive hyperplasia. Causes देख लो primary के parathyroid adenoma, parathyroid hyperplasia, parathyroid carcinoma. Secondary के क्या है? It is because of chronic hypocalcemia, secondary renal failure, vitamin D deficiency, malabsorption, and lithium consumption. And your reactive is because of post-renal transplant. As simple as that. Now the classical triad that you have, so the classical pentad that you have, the classical pentad for the hyperparathyroidism. It is your kidney stones, painful bones, abdominal groans, psychic moans, and fatigue overtones. This is the classical pentad that you have. Now, kidney stones, the composition, it is usually calcium oxalate and it is calcium phosphate. It is calcium phosphate. Here, patient will present to you with recurrent ureteric colic. It is going to be having a recurrent ureteric colic. It will be presentation. Excessive calcium in kidneys will result in nephrocalcinosis. It will result in nephrocalcinosis. Now, painful bones is because of increase in osteoclastic activity. Now, this osteoclastic activity increases, it decreases the bone mineral density. Now, because it decreases the bone mineral density, the weight bearing capacity would decrease. Now, as the weight bearing capacity decreases, it will result in painful bones, as simple as that. Now, when you talk about the abdominal groans, it is because of peptic ulcer disease, because of hypergastrinemia. Can anyone tell me why there is excessive gastrin produced in hyperparathyroidism? Reason for presence of peptic ulcer disease or hypergastrin. Very good, beta. Hypercalcemia stimulates G cells, and that G cells produce gastrin. That gastrin causes peptic ulcer disease. It can result in cholelithiasis. It can result in cholelithiasis. This cholelithiasis will present to you as cholecystitis, causing abdominal pain. This can also result in recurrent pancreatitis due to pancreatic ductal stones. Psychic moans, we don't know why. Fatigue overtones is because of proximal muscle neuropathy. It is because of proximal muscle neuropathy. It is because of proximal muscle neuropathy secondary to hypercalcemia. Secondary to hypercalcemia. Okay. How do you investigate? There is a misprint here. It is not for tertiary hyper. There is only primary and secondary, not for tertiary. So we know that a primary hyperparathyroidism is because of excessive parathyroid hormone secretion. So parathyroid hormone will be high, causing serum calcium to elevate. Another function of the parathyroid hormone is to excrete the phosphate via the kidneys. So if the parathyroid hormone increases, it causes increase in excretion of the phosphate via kidneys. This will decrease. In secondary hyperparathyroidism, it is because of chronic hypocalcemia, compensatory parathyroid hormone will increase. It might become normal. So here the kidney status matters. We see if the kidney is normal, you will see because of increase in parathyroid hormone, the phosphate will decrease. If the kidneys are damaged, like renal failure, then the phosphate cannot excrete. It will remain high. What are the X-ray findings that you will see? The first thing that you will see is presence X-ray of the hand is presence of subperiosteal resorption. It will result in subperiosteal resorption. What do you mean by this? Now you can see it is the radial aspect, as I can see thumb, and this is the ulnar aspect, that is a little finger. Now on the radial aspect, this is the proximal phalanx, this is the middle, this is the proximal phalanx, this is the middle phalanx, and this is the distal phalanx. In the middle phalanx, you see there is bone loss, and this is what we call a subperiosteal resorption. So subperiosteal resorption, it is most commonly seen on the radial aspect of the middle phalanx. It is most commonly seen on the radial aspect. It is on the radial aspect of the middle phalanx. It is on the radial aspect of the middle phalanx. On the skull, you will see presence of salt and pepper appearance. It is going to be salt and pepper appearance. Whereas in the vertebra, you can see is the vertebra, and this is the gap that you see. So there is bone density is decreasing, and this is what we call it as the Rugger Jersey spine. This is what we call it as the Rugger Jersey spine. Absolutely correct. Okay. So three important X-ray findings: subperiosteal resorption, salt and pepper appearance, Rugger Jersey spine, all for your primary hyperparathyroidism. Okay. Now, if they say what is the investigation of choice for primary hyperparathyroidism, the answer is going to be your Sista maybe scan. But if I change the question, that what is the best investigation? The best is going to be 4D CT. The best will be your 4D CT. There is no change. Okay, absolutely correct. Now, how do you address it if you have, first of all, how do you differentiate adenoma and your hyperplasia? In parathyroid adenoma, any one gland will be enlarged. In parathyroid hyperplasia, all four glands will be uniformly enlarged. So adenoma, I will only excise the gland which is affected, which is called as parathyroid adenectomy. It is called as the parathyroid adenectomy. In a parathyroid hyperplasia, I will remove three glands completely and I will remove the fourth gland half, right? Three complete gland and the fourth one will be removed half, and this is what we call it as 3.5 surgery. The other half of the parathyroid gland, is going to be re-implanted. It is going to be re-implanted on the ipsilateral sternocleidomastoid muscle. Absolutely correct. Reimplantation on the ipsilateral sternocleidomastoid muscle. So this is the difference between the management of parathyroid adenoma and the parathyroid hyperplasia. Clear? Okay, do not goof up on that. So, okay, we have already dealt with this. So this is done. Going into the thyroid component. Okay. So when I talk about the FNSC of the thyroid swelling, what is the optimum cytology criteria? This is your exam question. For an optimum cytology, remember the size of the needle that you have to use is anywhere between 22 to 26 gauge needle. Single best answer will be a 23 gauge needle. Minimum 2 aspirates. There should be 6 follicles per aspirate and 10 to 15 cells per follicles to call it as an optimum cytology. So criteria for optimum cytology, the size of the needle has to be 22 to 26 gauge, 2 aspirates, minimum 6 follicles per aspirate, and 10 to 15 cells per aspirate. Is that clear? Is that clear? Quick feedback. Guys, if you feel it is too fast, you can let me know also. We can adjust the speed accordingly, but I want you to be absolutely attentive. Clear? All is fine. Chalo. Okay. So on the basis of this thyroid categorization, on FNSE, we have a classification which is called as the Thai classification. So Thai classification is on the basis of FNSE. It is the FNSE criteria for thyroid swellings. Okay. Now we have number 1, which is called as the Thai 1 category. Thai 1 category is considered to be as a non-diagnostic aspirate. It is called as the non-diagnostic aspirate. Now, on the other hand, we have something called as Thai 1C, which is a non-diagnostic cystic aspirate. Then you have a Thai 2 category, which is a non-neoplastic swelling. This is your non-neoplastic swelling, that is Thai 2. Thai 3 is your follicular origin. Now remember FNSE cannot differentiate between follicular adenoma and follicular carcinoma. So we call it as simply as Thai origin. Thai 4 category is suspicious of malignancy. It is going to be suspicious of malignancy. Then you have Thai 5 category, which is a malignant lesion. Now, the fun is not in knowing all this, because your exam question is, how would you like to address? So the management is the question, right? Now, if you have a non-diagnostic or a non-diagnostic cystic aspirate, what will you do? I'm going to repeat FNSE under ultrasound guidance. If it is a non-neoplastic swelling, then do nothing. If it is a follicular origin of suspicion of malignancy, take the patient for lobectomy with frozen section to confirm the diagnosis. Malignant lesion, you will go ahead with stage-wise management. You'll go with stage-wise management. Clear? So this is with respect to high classification. अगर लैग हो रहा है तो बता देना, वहां पे एक 10 सेकंड का पॉज ले लेंगे एंड देन विल कंटिन्यू. So chat box is running fine, so you can let me know, not an issue. Now, inflammatory thyroid swellings is going to be a repeatedly asked exam question. Quickly, we'll fill up the table, nothing more important. Okay, we've already done in this class. I want you to give me a okay, screen is lagging, voice is not lagging. Great. ठीक है. So class में already कर रखा है, quick feedback ले लेते हैं. Hashimoto's, what is the type of inflammation? This is an example of chronic inflammation. Decurvence is an example of subacute inflammation. Riddles is also an example of chronic inflammation. Hashimoto's is because of autoimmune disorder, whereas decurvence is post-viral. It is a post-viral upper respiratory tract infection. Riddles is mostly idiopathic. It is mostly idiopathic. Otherwise, it is going to be autoimmune. Otherwise, it is going to be of autoimmune nature. Now, pathophysiology, remember the antibodies that it is going to produce. So I've already written, it is going to be your autoimmune disorder. So it's autoimmune pathophysiology. Antibody is going to be your anti-thyroperoxidase antibody. There is no antibody here. It is going to be cross-reacting antibodies. The cross-reacting antibody here, it will be because of IgG4 class of antibodies. It is going to be your IgG4 class of antibodies. Okay. Achha, what is the HLA which is associated? HLA-B8, HLA-DR3, HLA-DR5. Remember, HLA-B8-DR3 is also seen in Graves' disease. If you add DR5, HLA-DR3, HLA-DR5, that is going to be your Hashimoto's. Here it is HLA-B35. There is no specific HLA for your Riedl's thyroiditis. Now, Hashimoto's is seen between 30 to 40 years. Decurvence can be seen at any age group, and this is seen in age above 50 years. All these disorders are more common in females when compared to males. All these disorders are more common in females when compared to males. Hashimoto's, what is the clinical presentation? There will be presence of midline neck swelling. There will be presence of midline neck swelling with signs and symptoms of hypothyroidism. It is going to be hypothyroidism. In decurvence, there will be midline neck fullness, not swelling. There is midline neck fullness with pain that increases during swallowing. Pain that increases during swallowing. Pain that increases during swallowing. So it's a midline neck fullness with pain that increases during swallowing that you will see in your decurvence. Riedl's thyroiditis will be presented with midline massive neck swelling. It's a midline massive neck swelling that is going to be present with signs and symptoms of hypothyroidism. With signs and symptoms of hypothyroidism is noticed. Okay. Now, if you look at this thyroid status initially, in the Hashimoto's, there is follicular rupture. So initially, it will be hyper. As the entire gland gets damaged, it will eventually become hypo. In decurvence, initial irritation with cross-reacting antibodies will cause hyper. It will become hypo intermediately. It will recreate its balance, eventually becoming euthyroid. So don't need to worry. Riedl's it is an autofibrosis from day one itself. So it is going to have hypo throughout. Now, Riedl's thyroiditis, it is going to mimic as your anaplastic cancer. So it is also associated with signs in terms of severe pressure symptoms. So when you say pressure symptoms, it is going to be dyspnea, dysphagia, and hoarseness of voice. Three symptoms: dyspnea, dysphagia, as well as hoarseness of voice. Beta, readers will not have pain. Readers will only have pressure. Readers is an autofibrotic form. It is going to be a chronic inflammatory disorder. Chronic inflammation is only going to cause fibrosis. For all these disorders, the investigation is going to be thyroid function test with ultrasound with FNSC. In D. curvis, because it is painful and acute inflammation is there, it is thyroid function test with ultrasound. Here it is thyroid function test with ultrasound with FNSC has to be done. Now in Hashimoto's, you can also look for your anti-TPO antibodies. So antibody titer can be done. So in Hashimoto's, another thing I can do a antibody titer. That is an anti-TPO antibody. Here also, because of IgG, I can do a antibody titer can be done across here. Management here, it is going to for Hashimoto's, it is lifelong thyroxine. Decurvins, on the other hand, it is self-limiting. Whereas here also it is going to be lifelong thyroxine. A note point to be remembered if a patient develops severe pressure symptoms. If patient develops severe pressure symptoms, for this, the surgery of choice is going to be hysterectomy. It is going to be hysterectomy, the surgery of choice. We do an hysterectomy to relieve the pressure symptoms. Okay. We'll take the lunch break at around 2:15 to 30. Once you're done with the thyroid, we can think about the lunch break. Okay. So see, this concept is very simple. There are 160 pages. So I need to finish at least 30 pages odd in each session. Okay. So let's say I finish 30 by 2:30. But the trick is very simple. It is all about basic concept. बेटा आज ही सब कुछ करा देंगे, टेंशन नहीं ले, ठीक है? चलो. So let's look at the thyroid cancer. Quickly talking about it. Origin of your papillary cancer thyroid is going to be thyroid follicles. Follicular cancer is going to be again thyroid follicles. Anaplastic is also thyroid follicles, whereas your parafollicular C cells is for medullary cancer thyroid. As simple as that. Remember, as I told you, the most common malignancy is going to be papillary cancer thyroid. But remember, most common in ectopic thyroid gland. In ectopic thyroid gland, it is follicular. Anaplastic is associated with the worst prognosis, whereas the one that is associated with multiple endocrine neoplasia 2, that is going to be your medullary cancer thyroid. Okay? So this is the baseline data. This is the baseline data that you should be aware of. Okay? Now, at what age would you see this? Somebody saying there's a lag. Is the lag manageable? Give me 1 second, guys. Is the lag manageable? Quick feedback. Is the lag manageable? Oh, sure. So age of presentation for papillary is going to be anywhere between 30 to 40 years. It is seen at a younger age group. Follicles is going to be 40 to 50 years. Anaplastic is seen in age beyond 50 years. Whereas medullary cancer thyroid, if it is sporadic, that is in general population, it is seen in age above 50 years. If it is associated with Men's syndrome, if it is associated with Men's syndrome, it is seen in age under 20 years, right? So that is by second decade of life. Clear? All these disorders are more common in females when compared to males. Remember the genes: BRAF mutation for papillary, PTEN for follicular, RET gene mutation associated. The RET gene mutation, it is associated with your medullary cancer thyroid. The risk factors are important. When you talk about the risk factors for your papillary cancer thyroid, the most important is the ionizing radiation exposure. So one is the radiation exposure. Another one is your thyroglossal duct cyst. For follicular cancer thyroid, it is your long-standing goiters. For follicular cancer thyroid, it is going to be your long-standing goiter. Anaplastic does not have any specific risk factors, neither do the medullary cancer thyroid as a specific risk factor. Clinical presentation here, remember it's simple one. This is going to be a solitary thyroid nodule-like presentation. It is your solitary thyroid nodule-like presentation with cervical lymphadenopathy, with associated cervical lymphadenopathy. If not this, then the patient can present to you with lateral aberrant thyroid. The patient will present to you with lateral aberrant thyroid. We have discussed the concept of lateral aberrant thyroid, that a patient is going to have a swelling in the lateral side of the neck. The midline of the leg remains absolutely fine. So when you do an FNSE, you find there's a thyroid follicle present. It indicates that the tissue which is migrated from the neck to the lateral side of the neck. ठीक है? तो lateral aberrant thyroid का मतलब ये है कि thyroid swelling बनी नहीं है, लेकिन already lymph node positive हो गया है. क्यों? क्योंकि papillary cancers ना, they grow very slow. They are slow growing lesions. So there are two possibilities that you have. Follicular cancer thyroid, on the other hand, just remember, it will have goiter-like presentation. Usually, it will have goiter-like presentation or STN, but mostly like goiter. STN is solitary thyroid nodule-like presentation or STN-like presentation, but more important, the most important pickup point is presence of pulsatile. It is a pulsatile forehead bony swelling. It is your pulsatile forehead bony swelling, which is going to result in this component. Okay, it's a pulsatile forehead bony swelling. So swelling in the neck with swelling here because of this pulsatile forehead bony swelling. It is because of osteolytic secondaries to flat bones. It is the osteolytic secondaries to flat bones. Here, anaplastic cancer is going to have a massive midline neck swelling. They'll have massive midline neck swelling. Along with that, it will have features of local infiltration. Along with local infiltration, it will have Berry sign positive. Berry sign is nothing but impalpable carotid pulse at its normal location. And the last one, it will be associated with pressure symptoms. This will be associated with pressure symptoms. Medullary cancer thyroid, remember the medullary cancer thyroid which is arising from the C cells. The C cells produce two compounds. One is a calcitonin, another one is serotonin, right? Now, when there is excessive production of serotonin, it will stimulate the GI mucosa, which will result in diarrhea. So here, solitary thyroid nodule-like presentation. There is solitary thyroid nodule-like presentation. Along with ST-like presentation, the patient is going to present to you with diarrhea. That is because of excessive amount of serotonin produced by medullary cancer thyroid. As simple as that. Okay? So these are with respect to your clinical presentation. The mode of spread for papillary cancer is lymphatics, follicular is hematogenous, anaplastic is direct. This is both lymphatics as well as hematogenous. This is both lymphatics as well as hematogenous, right? What is the most common site for secondaries? For papillary cancer thyroid, it is going to be lungs, whereas here it is going to be bones. Here also it is lungs. Medullary more common with liver when compared to bone. In the bone, remember for follicular cancer, it is osteolytic secondaries. It is your osteolytic secondaries. Whereas here, medullary, it is going to be osteoblastic secondaries. If you have a confusion, remember Sachin Tendulkar, master blaster, medullary is blastic secondaries. For all malignancies or suspected malignancies, I will do a thyroid function test with an ultrasound and an FNSC. That will be done here. Here also, I will do a thyroid function test with ultrasound. But when you do an FNSC, on performing an FNSC here, you will get a Thigh 3 valuation. Now, as we told you, Thy3 indicates a follicular origin as it cannot differentiate between follicular adenoma and follicular carcinoma. So the investigation of choice here is going to be lobectomy with the frozen section. It is lobectomy with frozen section. Rest everywhere, it is going to be the same. That is your thyroid function test with ultrasound with the FNSC that you'll see here. Okay. Everywhere it remains same. If they ask you what is the tumor marker, the tumor marker here is thyroglobulin. Here it is going to be calcitonin. As these are the markers for medullary cancer thyroid, which is usually LE. Now, what are the HP findings? You see these empty vacuolated cells. These are nothing but orphan ani nuclei. They are nothing but orphan ani nuclei. Then you see these concentric circles, these whorls of circles which are present. These are what we call it as Samoma bodies. These are what we call it as Samoma bodies. Samoma bodies are the example of dystrophic calcification. This is an example of dystrophic calcification. Now, what are the other sites where you have presence of dystrophic calcification that can be remembered by a small mnemonic, that is PSM. P stands for papillary variant of renal cell carcinoma. S stands for serous cyst adenoma. It is the serous cyst adenoma of ovaries. M stands for meningioma. M stands for meningioma. Right? Then you see these cells which are not getting stained, right? These cells which are not getting stained, these are called as the oxyphilic cells, right? So these are your abundant, that is excessive oxyphilic cells. Now these oxyphilic cells indicates the diagnosis of Hurthal cell carcinoma. It indicates the diagnosis of Hurthal cell cancer, which is an aggressive variant of follicular cancer thyroid. It is an aggressive variant of follicular cancer thyroid. And then you see there are these muscular strands which are going into the thyroid tissue. And this is what we call it as presence of amyloid in stroma. Presence of amyloid in stroma is a characteristic feature of medullary cancer thyroid. It's the characteristic feature of medullary cancer thyroid, as simple as. Okay. So these are the characterization for each individual component in your thyroid malignancies. Okay. Every single word that we have dealt with is going to be absolutely important. I hope everybody is crystal clear. Right. So everything that we discussed in thyroid is important, starting from optimum cytology criteria, inflammatory thyroid cancers, inflammatory thyroid swellings, and the thyroid cancers as well. Beta, keratin pearls will have clusters. Okay. On the ends, the Samoa bodies will have concentric whorls. Clusters, you can see the cell is coalescing. Whereas in Samoa bodies, you have these whorls of concentric circles. Okay. So do not get confused. If you want a better explanation, your pathologist will be able to give you a much better explanation. But from a surgical standpoint, this is what you have to remember. Okay. So we'll do one thing. We'll take a lunch break here, and then, or else we'll finish breast and then take a lunch break. ठीक है? Maria, अभी के लिए जो पढ़ा रहा हूँ वही important है. बाकी अगर आपको याद है, very good. Otherwise, you can chill. Stage याद करवा दो. चलो, आप पूछ ही रहे हो तो याद करा ही देते हैं. So when you talk about the TNM classification for your thyroid cancer, in TNM classification for thyroid cancer, you have T size, N is lymph node, M is going to be metastasis. So when we say T1 disease is going to be size less than 2 centimeters. T2 disease is size between 2 to 4 centimeters. T3A disease is going to be greater than 4 centimeters, but all limited to your thyroid component. Then you have T3B. It is T3B, any size that is involving strap muscles. Any size that is involving a strap muscle. But the problem is, how do you remember T4A and T4B? For that, we have a very simple concept. Pictorial. So this is the skin that we're talking about. Under the skin, you have the subcutaneous fat. मेरे साथ बोलते रहिए, स्किन के नीचे क्या है? Subcutaneous fat. Subcutaneous fat के नीचे क्या है? Under that you have a muscle that is called as the platysma muscle. Platysma muscle के नीचे you will see there is presence of the strap muscle that is present. So this is what we call it as the strap muscles which are present. Strap muscles के नीचे आपको क्या मिलेगा? You will find the butterfly shaped gland that we're talking about. That is going to be your thyroid gland. थायराइड ग्लैंड के जस्ट पीछे आपको क्या मिलेगा? यू विल फाइंड देयर इज ट्रेकिया. ट्रेकिया के पीछे आपको ईसोफेगस मिलेगा. ईसोफेगस के पीछे यू विल सी देयर इज वर्टेब्रा. In front of the vertebra, you will see there is presence of prevertebral fascia that is present. Laterally, you will see there is presence of carotid sheath. Carotid sheath में you have the common carotid artery, you have the internal jugular vein, and then you have the vagus nerve. ट्रेकियोइसोफेजियल ग्रूव में recurrent laryngeal nerve देखने को मिलेगा. ठीक है. Now, when we talk about this each individual component, as you can see that this is the strap muscle that we're talking about. So this entire section is what we are going to depict it as the strap muscle. So this is what we call it as the strap muscles. Okay? Now, when we talk about the different components, how do you remember T3A, T3B, T4A, T4B? Those are your exam questions. So T3A is the size more than 4 centimeters limited to thyroid gland. T3B, no, if you talk about any size of the tumor, any size of the tumor, if it is involving the strap muscles, it will automatically become T. This is going to be T3B. This is going to be T3B. Now, if a tumor is involving anything that is present right in the midline. So when we talk about the midline, that means you're talking about the subcutaneous fat. We're talking about the trachea. We're talking about the recurrent laryngeal nerve or the esophagus. If it is involving anything of this sort, this is considered to be as T4A. Involvement of subcutaneous lesion, that is skin, involvement of trachea, involvement of esophagus, all these or the recurrent laryngeal nerve, it is considered to be T4A. For a T4B, it should have lateral involvement, that is involvement of your carotid vessels or the carotid sheath, involvement of mediastinal vessels or the prevertebral fascia. This will be called as T4B, right? So any size, if it is less than 2 centimeters, it is T1 disease. 2 to 4 centimeters, it is T2 disease. More than 4 centimeters, it is T3A disease. Okay? So this is how you remember. This is T1 disease, this is T2 disease, and this is T3A disease. This is your T3A disease. Okay? TNM में T is important in thyroid cancer. I have quickly given it to you. This is what you have to remember with respect to the T staging, and that is going to be your exam question. Okay? Clear? So N में कुछ नहीं है. You have N0, there is no evidence. You have N1A if it is involving level 6 and the level 7. And N1B if it is involving anywhere between level 1 to level 5. M0, there is no evidence of metastasis. M1, there is evidence of distant metastasis. This is more than enough. ये डायग्राम याद रख लो, इसके सिवा कुछ याद रखने की जरूरत नहीं है. क्लियर है? चलो. So talk about the breast. Breast में सबसे important है BIRADS. BIRADS के full form breast imaging reporting and data system. Remember category 0 incomplete assessment repeat. Category 1, negative, it is for screening, do a routine screening, continue. Category 2 is benign, routine screening to be continued. Category 3 is your exam question, probably benign, follow up after 6 months. So exam में पूछेंगे कितने महीने के बाद आना है, follow up after 6 months. Category 4, suspicion of malignancy, do a biopsy. Category 5, highly suggestive, perform a biopsy. Category 6, biopsy proven, do a stage-wise management. This is what is going to be with respect to your BIRAT's categorization. Breast abscess, quick recap on breast abscess. What is the most common organism causing breast abscess? It is going to be your Staph aureus. Where does the Staph aureus comes from? It is going to the most common source. It is going to be the oral cavity of the feeding baby. It is the oral cavity of the feeding baby that harbors the Staph aureus and going to give to the mother while feeding. What is the clinical features? It will be the features of acute mastitis. There's going to be an acute inflammation. So anywhere in the body there's acute inflammation, it is associated Ruber, Calor, dollar tumor. Same things are going to be here. The patient is going to be presented to you with severe mastalgia. It is going to have a severe mastalgia. Along with severe mastalgia, patient is also going to have high-grade fever. There's going to be high-grade fever. There is tenderness on the breast while palpating. There is presence of tenderness over breast. This can present to you with presence of erythema over the breast. Acute mastitis will also present to you with Piode orange. We all remember Piode orange in malignancy is going to be because of obliteration of subcutaneous lymphatic. So severe mastalgia, high-grade fever, tenderness is there, erythema is present, Piode orange. And remember, clinically, there is something called as the fluctuation sign. Remember, fluctuation sign in breast abscess is going to be delayed. It is not present as an early presentation. So conditions which are associated with delayed presentation. The first one we have marked it here. This is going to be your parotid abscess with delayed fluctuation sign. Second is going to be pectoral abscess. So when we say pectoral abscess, it is same of breast abscess. 3 is going to be your palmar abscess. 4 is your perineal abscess, and last one is your plantar abscess. So all these abscesses are going to have delayed fluctuating sign. Do not forget about it. We have discussed it before. It's a quick recap that you need to understand. Investigation of choice is going to remain as ultrasound. First line management is going to be USG guided aspiration. It is USG guided aspiration with antibiotic. If it fails, then you will go ahead with radial incision and drainage. It is going to be radial incision and drainage of abscess with antibiotic coverage. With the antibiotic coverage, that is what all that for a lactational mastitis. Okay. Now, in the breast surgery, quickly recapping that what are the common simple mastectomy. In a simple mastectomy, what are the structures? But a mammography jo hai, that will be covered in radiology. So I'm not going to do an overlapping topics without wasting time. So simple mastectomy, what are the components that we are going to remove? In simple mastectomy, I will remove the entire glandular component of the breast. I will remove the entire stroma of the breast. Along with that, I am also going to remove the nipple as well as the areolar complex of the breast. This is what we call it as simple mastectomy. Radical mastectomy is also referred to as the Halsted's surgery. Halsted's is called as radical mastectomy. In radical mastectomy, I will perform simple mastectomy. Along with simple mastectomy, I will remove the pectoralis major muscle. I will also remove the pectoralis minor muscle. After removing the muscles, I am going to remove all 3 levels of lymph node, that is level 1, level 2, and level 3 group of lymph nodes. So level of lymph node, that is level 1, level 2, level 3 will be removed. This is your radical mastectomy. Now, radical was getting too radical, so we have modified radical. In the modified radical, we are doing simple mastectomy. Along with simple mastectomy, I will remove pectoralis fascia, not the muscle. Along with that, I will remove the levels of lymph node, that is level 1, level 2, and the level 3 group of lymph nodes. Remember the examples of your modified radical mastectomy. We have Patty's surgery. We have the Scanlon's surgery. And the last one that you have is the Auchincloss method of MRM. In fact, Auchincloss is now the most common variety. It is the most common variety of the modified radical mastectomy. Absolutely correct. Okay. What are the structures to be preserved in MRM? Can be remembered as ABCD. A stands for axillary vein. B stands for Bell's nerve. The Bell's nerve is your long thoracic nerve. There is a long thoracic nerve. C stands for the cephalic vein. And D stands for nerve to latissimus dorsi. It is nerve to latissimus dorsi. It is the nerve to latissimus dorsi. Correct? So what are the complications that you're expecting in a modified radical mastectomy? Can be remembered a small mnemonic, that is SWAB. S stands for seroma formation, which is the most common complication. W stands for winging of scapula. As somebody has rightly pointed out, winging of scapula is because of damage to the long thoracic nerve. A stands for arm edema. This is the most common. See, post-axillary dissection in breast cancers is the most common cause for upper limb edema. B stands for blackening. Black indicates presence of flap necrosis. Now, all these are considered to be as an early post-operative complication. These are your early post-operative complications. All these are considered to be as an early post-operative complications. Now, if I superimpose that with the late one, so sometimes a patient who has underwent a modified radical mastectomy, it will take around 5 to 10 years later. They present to you with lymphangiosarcoma. That's a patient has underwent a modified radical mastectomy. After 5 to 10 years, the patient will present to you with lymphangiosarcoma of upper limb. Now, this lymphangiosarcoma of the upper limb is what we call it as the Stewart-Travis syndrome. This is what we call it as the Stewart-Travis syndrome. So, late complication is Stewart-Travis. Early complication is going to be seroma, wing of scapula, arm edema, as well as blackening of the skin. In the option MRM and long thoracic nerve, both are mentioned. What will be the answer? Pradeep, I didn't get your answer, beta. I mean, your question. Could you reframe your question? Yes, the management, rightly said, for the Stewart-Travis syndrome is going to be the 4-quarter amputation. It is a 4-quarter amputation. You remove the entire arm of that side, the scapula of that side, as well as the clavicle of that side will be removed. This is what we call it as a 4-quarter amputation. Okay. So these are the high yielding points in the breast that you're supposed to know. Okay. So we'll take a lunch break here, 45 minutes. But a management of thyroid cancers, now if it is papillary and follicular, we call it as well-differentiated thyroid cancers. If it is limited to thyroid cancer, then do a total thyroidectomy. If it is involving the lymph nodes, central lymph nodes, then central neck dissection, lateral lymph nodes will do it, modified radical neck dissection. Anaplastic cancers are inoperable. It is going to be only palliative management. Whereas for medullary cancer, thyroid, if the tumor is limited to thyroid gland alone, then you have to do a total thyroidectomy with prophylactic central neck dissection. Involvement of lymph nodes, you have to go with modified radical neck dissection. That is more than enough. Okay. But of Stewart-Travis syndrome, it is not preventable. If it is bound to happen, it will happen. There's nothing more. I mean, this should be like that. What is the cause of wing of scapula? Then the option we'll choose, like option available is modified radical mastectomy, long thoracic nerve damage. But if the option is given between, they can never give an option like that. But if you're given, you will choose the damage of long thoracic nerve because that results in wing of scapula. That damage can occur during MRM, but not every patient of MRM will have a long thoracic nerve damage. Okay. Yeah. Sure. So let's break it down for here. 45 minutes. We'll resume back with the vascular surgery. Until then, sit back and chill. Sure. Let's continue, guys. I hope everybody is back. Can we start? Can we start? Quick feedback. Okay, sure. So we're talking about the vascular disorders. I have a comparative data to be compared between the Burgess and the atherosclerosis. The age of presentation of Burgess will be under 40 years. The age for atherosclerosis will be about 50 years. The most important risk factor for Burgess is going to be smoking. Here it is going to be obesity. The most common limb involved in Burgess. Burgess do not differentiate. Remember, all four limbs are equally involved. Whereas in atherosclerosis, it is the lower limb, which is far more common involved when compared to the upper limb. The size of the vessels involved in Burgess is going to be small to medium-sized blood vessels. I hope everybody knows atherosclerosis is large to medium-sized blood vessels. It is large to medium-sized blood vessels. What is the pattern of involvement? Here it is going to be skip lesions. Here it is going to be a continuous lesion. So the progression for the Burgess, it is going to be from the distal to the proximal end of the vessel. Opposite for atherosclerosis, it is going to be from the proximal end of the vessel to the distal end of the vessel. This is not only limited to involvement of the blood vessel, that is artery, it is going to involve the artery. It is going to be involving the vein. Along with the artery vein, it is also going to involve the nerve as well. Atherosclerosis only going to involve the artery. Now, in order to know this of the disease, you need to understand the ABPI index. So that is ankle brachial pressure index. The measure is by systolic blood pressure at the level of ankle to that of systolic blood pressure at the level of brachial artery. It is systolic blood pressure at the level of brachial artery. In general, systolic blood pressure is 120 millimeters. So when you look at the ratio, should be 1. So the normal is going to be 1 to 1.3. For a calcified blood vessel, it will be more than 1.3. Intermittent claudication less than 0.9, rest pain less than 0.5, critical limb ischemia less than 0.3. Unfortunately, you have to remember all these numbers. There is no exception to this rule. Okay. Now, when you talk about atherosclerosis specifically, so this is about the atherosclerosis. In atherosclerosis, the occlusion can be at iliac, iliac and femoropopliteal. We have already revised in our exam. Now, remember, or in our regular classes, the intermittent claudication will be bilateral here. It will be unilateral in these two. There will be involvement of gluteus, thigh, and calf. Gluteus will be spared here. There will be gluteal sparing here. Okay. It will be your gluteal sparing, but the thigh and the calf will be involved. In femoropopliteal, gluteal thigh is spared, only calf is going to be involved. Management for iliac occlusion is your bifemoral bypass. It is your bifemoral bypass. Whereas iliac occlusion is going to be your femoral bypass. It is going to be an iliofemoral bypass. For femoropopliteal occlusion, it is going to be an iliopopliteal bypass. Now, what is the material used? Remember, the most common material used for all these graftings. Here it is Dacryl. Here also it is Dacryl. Here it is going to be autologous reversed great cephalosporin. It is the great cephalosporin of the same patient which we are going to use it in order to create a in order to create a bypass, right? So this table itself is very, very important. The entire vascular surgery and arterial disorders, this is one table that you have to revise before going to the exam. Now, in terms of varicose vein, C classification is important. I don't need to emphasize it again and again. C0 indicates there is no disease, right? So there is no abnormality or there is no evidence of any disease. C1, there is presence of telangiectasia. So when I say telangiectasia, it is basically less than 1 millimeter in diameter vessel, or it can be a reticular vein. For a reticular vein, it is going to be between 1 to 3 millimeters in diameter. If it is more than 3 millimeters, it is what we call it as varicose vein. If the size of the vessel is more than 3 millimeters in diameter. C2R is your recurrent varicose vein. It is a recurrent varicose vein. C3 is presence of edema around ankle. C4A is pigmentation. This pigmentation is because of a condition that is called as hemosiderosis. Hemosiderosis is described as hemosiderin with melanin. It is hemosiderin with the melanin of the skin. C4B is what we call it as the lipodermatosclerosis. The lipodermatosclerosis is also commonly referred to as the woody limb. Or what is the characteristic appearance that you have? You are going to have the inverted champagne bottle appearance. It is the inverted champagne bottle appearance that you're going to see. C4C is what we call it as coronophlebectatica. It is your coronophlebectatica, right? C5 is your healed venous ulcer. It is your healed venous ulcer. C6 is your active venous ulcer. C6R is your recurrent venous ulcer. C6R is your recurrent venous ulcer. Okay. So these are with respect to C. Now EP, that is with respect to etiology. P stands for primary. S stands for secondary. It is not EN, we say EC. EC is congenital. PR is reflux of blood. O is obstruction to the blood flow. It is obstruction to the blood flow. RO is reflux with obstruction to the blood flow. O is no pathophysiology found. AS basically means the anatomical structures involved. AS is your involvement of superficial venous system. AD is involvement of deep venous system. AP is involvement of perforator system. And no anatomical site notice, that is AN. Now, in a varicose vein, whenever there is saphenofemoral junction incompetency, when you do a duplex scan, which is the investigation of choice, in the duplex scan, we find a presentation which is called as the Mickey Mouse sign. Called as the Mickey Mouse sign. Now, in the Mickey Mouse sign, I hope everybody is able to identify there are two ears which are present here and a big face that is present. The big face is going to be the common femoral vein. This is going to be on the one great saphenous vein. Another one is your common femoral artery. So it is your common femoral artery, the great saphenous vein, and the common femoral artery. So common femoral artery, common femoral vein, and the great saphenous vein. Okay? So this is with respect to the duplex scan, right? Now, the management of Trendelenburg is done by Trendelenburg surgery. This is done for great saphenous vein varicosity and the short saphenous vein varicosity, right? So for them, Trendelenburg surgery, there are three things that you'll do. That is flush, ligate, and strip. There is flush, ligate, and stripping. Remember, below knee stripping is contraindicated. Stripping basically means to remove the vein out of the body. So below knee stripping is contraindicated because when you're trying to strip the great saphenous vein, it will cause damage of your saphenous nerve. Now, to prevent the damage of saphenous nerve, we should not strip below the knee. That is a great saphenous vein. And short saphenous vein, it is going to cause damage to the sural nerve, right? Absolutely correct, Garima. Very good. Okay. What is sclerotherapy is done? Sclerotherapy is done if the size of the vein is less than 3 millimeters in diameter. So it is usually done whenever there is a perforator incompetency. So it is done for perforator incompetency or it is done for recurrent varicose vein. It is done for perforator incompetency or also resulting in recurrent varicose vein. So what are the agent that you're going to do? Remember, the most common agent is going to be the sodium tetradecyl sulfate. It is going to be called as the Tasari's method. This Tasari's method is also called as foam sclerotherapy, also referred to as foam sclerotherapy. So can anybody tell me what is the ratio in which I'm going to put I am going to put the scare to the sclerosing agent? Very good, guys. Who is that? Okay, Meghna, you're correct. Sajan Kumar, you're correct. Garima, you're correct. Arun, no. So answer here is 4:1. 3:1 उसका ratio पे 3:1 3:2 बोल रहे हो ना. Remember, it is in type or I can say class 3 hemorrhagic shock. Class 3 hemorrhagic shock में ना आगे चल के पढ़ ले. Class 3 hemorrhagic shock में I will give crystalloids combined with colloid in a ratio of 3:1. तो यहाँ पे आंसर 3:1 है. ठीक है. यहाँ पे it is 4:1 only. Bisgard's regime is done for venous ulcer. It is done for venous ulcer. ठीक है. So when talk about venous ulcer, Bisgard's regime, E stands for educate the patient regarding the ulcer and daily dressing. E stands for elevation of limb, that is limb elevation. And last, E stands for usage of elastic compression stockings. Usage of elastic compression stockings. It is the usage of elastic compression stocking. So educate, elevate, and elastic compression stocking. Somebody was asking me, sir, how do you differentiate between a venous ulcer in comparison to that of an arterial ulcer? Now, usually when you talk about it, it is the area that is going to be present. Venous ulcers are usually seen at the gaiters area. It is at the gaiters area. Arterial ulcers are seen wherever you have poor vascularity and the end vasculature is usually noticed. So it can be seen in palms, it can be seen in soles, it can be seen on fingers, or I can say toes. These are the usual signs. Now here you would see there is presence of sloping edge. Here it is going to be the punched out edge. It will have punched out edge. Now this is a shallow ulcer. Venous ulcer is a shallow ulcer, whereas arterial ulcer is an example of a deep ulcer. It consists of pale, scanty, unhealthy granulation tissue. Unhealthy granulation tissue. Arterial ulcers, on the other hand, they have poor granulation tissue. Because of poor vascularity, It will not granulate only. So Gator's area, palms and so sloping edge, smashed out edge, shallow ulcer, deep ulcer, pale scanty unhealthy granulation tissue, and a poor granulation tissue. Okay? So this is how you differentiate between arterial and venous ulcer. I hope everybody is clear. Right? So these are the basic points that you should know with respect to venous disorders. Now we have another one, that is your DVT. Virtue of striatum in DVT is basically presence of a endothelial injury. There has to be presence of an endothelial injury. Along with that, there has to be hypopressor and hypercoagulable state. There is this hypercoagulable state that is present. So endothelial injury, hypostasis of blood flow, and hypercoagulable state. The most common site for DVT, it is going to be the calf veins. Most common site for DVT causing pulmonary embolism, it is your femoral vein DVT. It is with the femoral vein DVT. Now, the management for any DVT is going to be anticoagulation and will be starting with low molecular weight heparin as well as warfarin on day 0. Continue both of them until the 4th day. On the 5th day, I am going to stop low molecular weight heparin, continue only on warfarin. The day we stop the low molecular weight heparin, switch to warfarin. This is what we call it as the warfarin switch over type. This is what we call it as the warfarin switch over time. Now, whenever you're giving warfarin, remember the target INR is between 2 to 3. Whenever the INR is less than 2, increase the dose of warfarin. Whenever the INR is more than 3, decrease the dose of warfarin. DVT, which is having a contraindication for anticoagulation. Example like recent history of stroke. Example like recent history of stroke. For that, I will give an IBC filter, which is also commonly referred to as the green field filter. Also referred to as a green field filter. देखो INR का जो टारगेट है ना वो 2 to 3 है, तो जब भी INR 2 से कम होगा तो वॉरफरिन का डोज बढ़ाना है, और जब भी INR 3 से ऊपर चला जाएगा वॉरफरिन का डोज कम करना है, लेकिन INR 2 से 3 के बीच में ही रखना है. So the target INR is between 2 to 3. Now, if a patient develops HIT syndrome, that is heparin-induced thrombocytopenia. If patient develops heparin-induced thrombocytopenia, अगर पेशेंट को हिट सिंड्रोम है, so what will you do? The current recommendation says stop heparin immediately. Stop heparin immediately, and you have to switch to number 1. You can go with fondaparinux. We have rivaroxaban, apixaban, and bivalirudin. Right. So when you talk about the fondaparinux, it is a 10A inhibitor. Rivaroxaban is 10A inhibitor. Your apixaban is also 10A inhibitor. These are factor 10A inhibitors. Bivalirudin is your direct thrombin inhibitor. DTI is a direct thrombin inhibitor. Okay. So these are with respect to your HIT syndrome. Achha, how long will you give warfarin? Remember, warfarin, if it is the first episode of DVT, it is given for 3 months. If it is a repeat recurrent episode of DVT, the warfarin has to be given for lifelong. It has to be given for lifelong. Correct. Rahul, absolutely correct. So this is all the important points of DVT that you should be aware of. Now, quickly talking about the plastic surgery part. In the plastic surgery, we'll be discussing about the partial thickness skin graft and a full thickness skin graft. Screen is moved. Okay, got it. The partial thickness skin graft is also called as the Thier's graft, also called as SSG. SSG stands for split thickness skin grafting. Full thickness is what we call it as Wolfie's graft, right? The device used to extract the graft is what we call it as the Humbee's knife. Another one is your electric dermatome. Both of them can be used. How do you know you have taken the right amount of thickness? If there is presence of a punctate hemorrhage from the grafting side, that is an ideal criteria to tell you have taken a partial thickness skin graft. And if the subcutaneous fat is exposed, you have taken a full thickness skin graft. Now, when you look at the comparison, between the donor sites. The defect of donor site here in partial thickness is going to be a temporary one, whereas here it is going to be permanent, right? The scar, there will be no scar here. It will leave a scar at the donor site. Because it's a temporary defect, you can take any size. Here, it is only small size is permitted. Repeat grafting is possible from the same donor site. It is not possible. The repeat grafting is not possible from the same grafting site. The most common site, that is the donor site, when you're going to go take a partial thickness skin graft, it is going to be from the lateral aspect of the thigh. It is from the lateral aspect of thigh. On the other hand, if you're taking a full thickness, skin grafting, then it is going to be retroauricular, that is behind the ear, right? Now look at the graft. Graft survival is good in partial thickness, whereas poor in full thickness. Here you have more of secondary contraction when compared to primary. Here you have more of primary when compared to secondary. Cosmetic outcome is poor here, whereas the cosmetic outcome is good in a full thickness skin graft. As the graft does not bring its own blood supply, it is relying on the blood supply from the surrounding organs. So hence graft survival is better if the requirement is less. So the thickness is less, requirement is less. Hence the partial thickness grafting will survive better when compared to full thickness. What is a primary and a secondary contraction? The minute you take the graft from a donor side, it contracts immediately. That is called as primary contraction. And after applying at the recipient side, when it contracts, it is called a secondary contraction. So whenever the secondary is more when compared to primary, it will cause crumpling after putting, resulting in poor cosmetic outcome. That is simple logic that you need to follow. Right now, what are the causes for graft failure? Remember, the most common cause for the graft failure is going to be your hematoma formation. The second one is seroma. How do you prevent the hematoma and seroma collection? And this is what we call it as a pie crusting. Now, the technique is called as pie crusting. In the pie crusting, you're making small holes on the graft, and through that holes, you will see that the both seroma and hematoma will escape. So it will prevent the collection. The another added advantage of the pie crusting is it increases the surface area of the graft. It increases the surface area of the graft by any between 1.5 to 6 times. That means a 10 centimeter graft can be stretched to 15 to 60 centimeters. The other causes you have is repeated movement at the graft site, right? So if there is a joint and if a joint moves, obviously the graft failure will occur. To prevent that, you need to go with immobilization of joint. You can put a slab so that it confers in that area. The fourth one is infection. That is why you should always perform a preoperative culture. Remember, presence of beta hemolytic streptococci. Presence of beta streptococci is an absolute contraindication for skin grafting. And the last complication is going to be or a graft failure if there is absence of perios or the bony surface. These are the causes. For your graft failure: hematoma, seroma, repeated movement of graft siting. If there's preoperative or the culture is not done properly, if there's an infection on the wound bed, and absence of periosteum. These are the causes for graft failure. So when would you like to go ahead with the cleft lip and cleft palate repair time? If it is a unilateral cleft lip, then you can do between 5 to 6 months of age. For bilateral, go ahead with 4 to 5 months of age. Sorry. For soft palate repair, it is 6 months, whereas hard palate repair, it is at 18 months. Now, if you have a cleft palate, which is going to be both soft and hard, so you require only this cleft palate, you require 2 surgeries. Soft palate will be done at 6 months. Hard palate will be done at 18 months. It will be done at 18 months. If there is a cleft lip and palate which is unilateral, again it will require two surgeries. You will do a cleft lip with the soft palate repair between 5 to 6 months, and the hard palate repair will be done at 18 months of age. If it is bilateral, again it will require two surgeries. Now here you have bilateral cleft lip, so you will do a lip repair with the soft palate repair between 4 to 5 months, but the hard palate repair will be done only at the age of 18 months. So all these repair criteria with respect to age is important. I would recommend you to remember these four, and a combination of four is nothing but your both palates, your lip and palate bilateral. Okay, clear? So this is about your cleft lip and the palates repair time. Now, talking about the nutrition, again, a very, very important topic. What is the current indication for TPN? I hope everybody knows TPN stands for total parenteral nutrition. It is your total parenteral nutrition. So there's a short bowel syndrome is the first indication where the length of the small intestine is less than 200 centimeters. High output enterocutaneous fistula where the output is more than 500 ml. There's an output of more than 500 ml in 24-hour period. Presence of acute inflammatory bowel disease, initial phase of acute pancreatitis, and prolonged ileus are the indications for total parenteral nutrition. Right. So when you talk about the composition, now here is an important thing about the status. Right. So when you're talking about the TPN concentration, you should always know how much energy is released for the amount that we are going to put across. Okay. So the highest percentage overall is going to be of the carbohydrates. The carbohydrate accounts for 40 to 50%. It's going to be 40 to 50%. And this is going to give me an energy of 3.5 kilocalories per gram. Fat is going to be 30 to 40%. It will give you 9 kilocalories per gram. Proteins is going to be 20 to 30%, and this accounts for 4 kilocalories per gram, and rest of them are going to be trace elements. It is going to, sorry, 10 to 20, not 20 to 30. It's 10 to 20%. So it is going to be 10 to 20%. It is going to be accounting for 4 kilocalories per gram. Okay. You need to remember how much energy is released, because they can ask you that 10 grams of carbohydrates are given, 50 grams of fat, 60 grams of protein. What is the total energy that is going to go into the person? So you have to calculate the energy based upon this. Now, these are going to be in trace elements. Or they're going to be not, they'll be in a very minute quantity. So it is negligible. Or you can, it's not negligible, I'd say it is not quantifiable. Okay. The very little, so talking in terms of percentage is not adequately perceived here. Now, what are the complications associated? Complications associated with total parenteral nutrition. So what is a tube-related complication when you talk about it? Or tube or rancing line related? So when you're inserting the line, okay. Now the first one, it can cause injury to the pleura, resulting in pneumothorax. It can result in development of air embolism. It can result in thoracic duct injury. It will result in thoracic duct injury. Can result in cardiac tamponade. It will result in cardiac tamponade and line sepsis. It is the line sepsis. Remember, the most common line-related complication is line sepsis. Feeding related one, yes, this is where you have the refeeding syndrome. In a refeeding syndrome, remember, as soon as you give excessive amount of sugars, the insulin will suddenly increase, pushing the potassium away. So first thing, there's hypokalemia. There is hypomagnesemia associated with hypophosphatemia with thiamine deficiency. With thiamine deficiency, right? All these put together is what we call it as the refeeding syndrome. So hypokalemia, hypomagnesemia, hypophosphatemia with thiamine deficiency is your refeeding syndrome. Remember, refeeding syndrome can be life-threatening also. So this is with respect to nutrition. All important points, we have covered it in a single go. Now, coming to one of the most important topics, that is going to be trauma. But before that, you need to give me 2 minutes time. We'll resume back. Just give me 2 minutes. All right, guys. So let's continue. So we're talking about trauma. I hope everybody is ready. Trauma is going to be a little bit tricky, but we're going to do it in a very precise and a simplified manner so that you don't go for. Okay. Okay. So when you talk about trauma, the first thing that you have to do is triage. Remember, triage, the criteria for doing a triage, I've given you one criteria, another criteria that you need to know. It is basically on the basis of outcome, not on the basis of severity. So triage is done on the basis of outcome. It is not on the basis of, or it is not on the basis of the severity. Now, triage, there are color codes which are going to be present. Black basically means broad, dead, it is least important. Red is emergency, which requires an immediate attention. Yellow is urgent, and green requires a delayed attention. It requires a delayed attention. Okay. So these are the components that is with respect to the triage categorization, right? Now, when we talk about the shock in the trauma, one of the most important shocks that we talk about is your hemorrhagic shocks, right? So when you talk about the hemorrhagic shock, 1 second, guys. Sorry, there's a small disturbance from the hospital end. Okay. Okay, sorry. Right. So when we talk about the various forms of shocks, class 1 hemorrhagic shock, the percentage of blood loss is going to be 15%. If it is 15 to 30%, it is class 2. 30 to 40%, it is class 3. And more than 40% of volume loss is called as class 4 hemorrhagic shock. Remember, in class 1, heart rate remains normal, blood pressure remains normal, pulse pressure remains normal, respiratory rate is normal, urine output is normal, GCS is normal, there is no need for blood transfusion. Okay. In a class 2 hemorrhagic shock, you will say the heart rate will increase, the systolic blood pressure will remain normal, the pulse pressure which is present, the pulse pressure which is going to be present is going to narrow down, or I can say it will decrease. Respiratory rate may remain normal or increase. Urine output remains normal. GCS, here the patient is going to become anxious. There will be anxiety. Here also there is no need for blood transfusion. In class 2 hemorrhagic shock, you see the pulse rate picks up, systolic blood pressure drops, pulse rate drops, respiratory rate increases. It becomes oliguria, that is decreased urine output. Patient is confused, and here the probability is there, so blood transfusion is required. Class 4 pulse rate picks up more, systolic blood pressure falls, pulse pressure falls, respiratory rate increases, it becomes anuria, that is complete absence of urine, and patient is unconscious. For these patients, you now need to have massive blood transfusion. It requires a massive blood transfusion. Now, the current criteria says in a massive blood transfusion, if it is more than or equal to 10 units of blood transfused within 24 hours, that is within 24 hours, this is what we call it as massive blood transfusion. Now, the current indication or a criteria for massive blood transfusion, it is you have to give your packed RBCs, you'll give PRBCs with fresh frozen plasma with platelets in a ratio of 1:1:1. Right? For emergency transfusion, it is O negative, which is preferred. For emergency transfusion, it is O negative that has to be given. In class 3 pulse pressure, class 3 pulse pressure is falling a bit. PP decreases, becomes further narrow. Okay. PP is pulse pressure, that is the difference between systolic and the diastolic blood pressure. So we talk about the head injury, again very important on the basis of GCS. When we say minor head injury, here the GCS will remain 15/15 with no loss of consciousness. 15/15 with no loss of consciousness. What is a mild head injury? Quick feedback. When do you call the patient is having a mild head injury? Criteria for mild head injury. The GCS here can be 14/15 or 15/15, but this time with loss of consciousness. Now, moderate is GCS between 9/15 to 13/15. If it is less than or equal to 8/15, it is considered to be as severe head injury. And this was our last year FMG question, or last session FMG question. Okay. I think last year. Another important indication is when would you like to do a CT within 1 hour? So indication of CT within the 1 hour of trauma. Number one, if the GCS is less than 13 at any point or less than 15 at second hour point. Focal neurological deficit is present. If there is skull fracture, more than or equal to 1 episode of vomiting and more than or equal to 1 episode of post-traumatic seizure. If more than or equal to 1 episode of post-traumatic seizure. Now, one of the major reasons why you need a CT is because of your traumatic head injuries, and they are EDH and SDH, right? EDH and SDH, all that you need to know, two important points. In EDH, extradural hemorrhage, there is collection of blood. There is collection of blood between dura and skull. Between dura and skull bone. The most common source of bleeding is going to be the middle meningeal artery. It is the middle meningeal artery. The most common source is going to be middle meningeal artery, and the most characteristic feature will be presence of lucid interval. It is going to be the lucid interval. The investigation of choice is going to be NCCT. In the NCCT, you see this is the opacity. Remember this image. It is your bilenticular opacity, or also called as the biconvex opacity, right? Management in emergency is going to be burr hole. In emergency, we will do a temporal burr hole surgery. It is going to be burr hole surgery. But if you talk about definitive management, for a definitive management, it is going to be craniotomy. Okay, so every single point is covered in the small box. ठीक है. हाँ ठीक है, याद रख लो यार, इडली शेप्ड इन ईडीएच. ठीक है, फिर यहाँ क्या याद रखोगे? एसडीएच के लिए कोई खाना बता दो यार. somebody saying इडली वाला शेप ईडीएच के लिए पहली बार सुन रहा हूँ मैं. ये कौन सा शेप हो गया? ये कौन सा शेप है? बनाना शेप. अच्छा, हाँ गुजिया. बनाना गुजिया. और बताओ, और कोई स्वीट बच गया? हम्म. हाफ डोसा ना. अरे बस 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 बस. मैं आई वाज आस्किंग फॉर, आपने बोला ना कि इडली, ई फॉर इडली, ई फॉर ईडीएच. एसडीएच के लिए बताओ. एस से, एस से क्या बोलोगे? एस से कौन सा खाना है? एस से इट्स लाइक अ सिकल शेप. नो, एस फॉर सिकल, एस फॉर एसडीएच. ठीक है. हाँ हाँ ठीक है ठीक है. हर कोई मेरे से ज्यादा स्मार्ट है. चलो, एसडीएच में क्या है? इट इज अ कलेक्शन ऑफ ब्लड. एसडीएच, देयर इज कलेक्शन ऑफ ब्लड between dura and arachnoid membrane. Between dura and arachnoid membrane. The most common source of bleeding. The most common source of bleeding, it is going to be your cortical bridging veins. It is going to be the cortical bridging veins. Now, if we talk about the most characteristic feature, the most characteristic feature would be a constant headache with dilated pupils. Headache with dilated pupil. Now, investigation of choice here is also going to be NCCT. In the NCCT, you will see one surface is concave, another one is convex. So it is concavo-convex opacity. Concavo convex opacity, also referred to as the crescent opacity. Also referred to as crescent opacity. In the management, if it is a small SDH, then it is observation. Observation. If it is a large SDH, then you have to take it for craniotomy. For large STH, you have to take the patient for craniotomy, right? So this is with respect to EDH and STH, Okay. Now, another very important component, that is a diffuse axonal injury. Diffuse axonal injury is described as complete disruption. It is your complete disruption of axons. It is a complete disruption of axons between the white matter and the gray matter. Here, patient is going to present to you with coma. And when you do an NCCT of the head, it comes out to be normal. To conclude the diagnosis, you have to do an MRI. And MRI will present to you with punctate shaped hemorrhage. It is the punctate shaped hemorrhage between the white matter and the gray matter. It is the punctate shaped hemorrhage between the white matter and the gray matter. Okay. You can see all these punctate shaped hemorrhages, which are pointed between the white matter and the gray matters. Okay. Now this is associated. This is associated with the worst prognosis. Post-traumatic coma without having any evidence of any bleed. Then you do an MRI, you will find presence of punctate shaped hemorrhage. Our previous exam question was the finding of your extradural hemorrhage and the finding of your subdural hemorrhage. This is very good. पहले 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 आप कर दो। But a subarachnoid hemorrhage is a sequelae of ruptured Berry's aneurysm, so that will be dealt in medicine. We're talking about traumatic hemorrhages. Okay? So all that you need to know in subarachnoid hemorrhage is presence of thunderclap headache. Okay? That's the most characteristic, the worst headache of life. That's the statement will be given. Nothing more than. Okay? So, guys, I'll take the questions at the end. Let me finish the trauma part and then we'll discuss. Okay? Now, Cushing's triad, it is seen in secondary brain injuries. In the secondary brain injury, which is due to raised intracranial pressure, right? So what do you see? The first thing that you will see, there will be presence of bradycardia. Along with bradycardia, it will have hypertension. Along with hypertension, it will have irregular respiratory rate. It will have a irregular respiratory rate. So bradycardia, hypertension with irregular respiratory rate together is what we call it as Cushing's triad. Now, what is the lethal triad of trauma? Again, your exam question. Lethal triad of trauma kya hai? Three important contexts. Presence of metabolic acidosis with hypothermia resulting in coagulopathy. So you have metabolic acidosis, hypothermia with coagulopathy is what we call it as the lethal triad of trauma. Now, to prevent the lethal triad of trauma, we have to follow DCS protocol, and DCS is what we call it as the damage control surgery. DCS stands for damage control surgery. Now, the damage control surgery, what is stage one? Stage one is patient selection. Stage two is your primary exploration. In the primary exploration, the goal it is to control hemorrhage. It is to control hemorrhage and prevent any further contamination. Prevent any further contamination. Prevent any further contamination. In stage two, I'm not going to do a definitive abdominal closure. I'll go to stage three where it is ICU care. This will last for 24 to 48 hours. The goal here it is to correct coagulopathy. Correct coagulopathy and prevent hypothermia. And prevent hypothermia. It is to correct coagulopathy and prevent hypothermia. Stage 4 is your secondary exploration. The goal of the secondary exploration, it is to basically correct the anatomy. It is basically to correct the anatomy. And the last one is stage 5. Stage 5 is your definitive abdominal closure. It is going to be a definitive abdominal closure. So we have patient selection, primary exploration, ICU care, secondary exploration, and definitive abdominal closure. So these are the points that you have to remember with respect to damage control surgery. Excuse me. Right, so let's continue. Another component of the trauma that you have is FAST, that is a focus assessment sonography for trauma. You have a 4P evaluation. What do you see in 4P? Number one is going to be your perihepatic space. After your perihepatic space, we will move to the pericardial space. From the pericardial space, we'll go to perisplenic space. And the last one that you will evaluate is going to be the pelvic space. It is going to be your pelvic space. Remember the minimum fluid required for fast to be positive. The minimum fluid collection for fast positive. The minimum fluid collection for fast positive should be of 100 cc. Okay? Less than 100 cc, it is very poor. Now we have something called as E-fast. In the E-fast, we are doing an extended. So यहाँ पे already have given that is 100 cc. Okay? So minimum fluid collection for the fast positive is going to be 100 cc. E-fast is nothing but extended fast. So in an extended fast, you are going to evaluate thorax also, right? So here we will do a right thorax as well as left thorax. I'll do a right upper abdomen, the right lower abdomen, left upper abdomen, and the left lower abdomen. So these are the contexts that you will be visualizing in the extended fast. Okay? Now, how do you know if there is presence of pneumothorax? Now, USG finding of pneumothorax. If I say USG finding of pneumothorax. So, USG finding of the pneumothorax. Number one, there is absence of seashore sign. Absence of seashore sign. The other ones that you have is a barcode sign. And one more that you have is a stratosphere sign. So absence of a seashore sign, then you have a barcode sign and a stratosphere sign. These are the various components of your pneumothorax. Okay. Now, coming to the splenic injury or the trauma that you have, what is the most common organ injury in abdominal trauma? Quick feedback. Most common organ injury in an abdominal trauma. Very good, guys. Very good. I'm happy that you know the update. That is your liver. But if I change to blunt, the answer will become spleen. If it is penetrating, it is going to be your small intestine. Sorry, it is going to be your liver. For car seat belt, it is going to be the mesenteric tear. It is going to be mesenteric tear. Whereas in the blast injury, abdominal organ, it is going to be your bowel. That is usually going to get injured. Okay. And yeah, bowel also, we are talking about small intestine. Maximum air composition is there itself. Okay. Now, grades of splenic injury and their management. Again, this has been your previous exam question. Grade 1, we're talking about the hematoma that is going to be subcapsular hematoma involving less than 10% of the total surface area and the depth of the laceration is less than 1 centimeters. Grade 2 is between 10 to 50% of the total surface area and the depth is between 1 to 3 centimeters. This is more than 50% of the total surface area greater than 3 centimeters. Now here it is going to have intraparenchymal hemorrhage. It is going to have a intraparenchymal hemorrhage with more than 25% spleen devascularized. More than 25% of the spleen is devascularized. When you talk about grade 5, it is completely shattered spleen. It is completely shattered spleen. That is, spleen is broken down into smaller components. For grade 1 and grade 2, it is going to be conservative management. It is going to be conservative management. For grade 4 and grade 5, you will go ahead with splenectomy because it is high grade injury. Now, for grade 3 injury, if it is stable, if the patient is stable, for a stable patient, we'll go with conservative management. If patient is unstable, I'll go with surgery. And surgery is spleen preserving surgery that is called as splenography. I'll do splenography. Okay. If it is going to be unstable, we'll do a splenography. Now, post-splenectomy vaccination is important. So whenever you're doing a splenectomy vaccination, we'll see whether it is an elective splenectomy or emergency splenectomy. Whether it is an elective splenectomy or whether it is an emergency splenectomy. Whether it is an elective splenectomy or whether it is a emergency splenectomy. For an elective splenectomy, I have to give vaccination that is 2 weeks minimum prior to surgery. So it is within 2 weeks prior to surgery. So you have to give at least 2 weeks prior to surgery. The vaccine that we give, it is your pneumococcal, meningococcal, and H influenza B. The H influenza B. Now talk about the emergency splenectomy. One that you have to give in immediate post-op. One that you have to give in an immediate post-op and one that is within 2 weeks. Immediate post-op and within 2 weeks of surgery. Immediate post-op, we will give pneumococcal. And in 2 weeks period of time, we'll give meningococcal and the H influenza B. Meningococcal and the H influenza B, right? So again, post-splenectomy vaccination has been an exam question. Which of them are to be given, especially about your emergency splenectomy vaccination? Your emergency splenectomy vaccinations. Okay? So this is with respect to traumatic vaccination that you have to take care. Hernia में एक छोटा सा mistake हुआ है. The entire chapter of hernia has gone in. ठीक है? So we don't need to revise the entire chapter. I'll be discussing only the inguinal hernia that is going to be important from our exam perspective. Okay? So the whole component is gone, but for a quick revision, we'll talk about the indirect and the direct inguinal hernia. Now, just for the sake of understanding, those who have attended the class, they'll understand. This is your deep inguinal ring. This is your superficial inguinal ring. I hope everybody knows that deep inguinal ring is a defect in the fascia transversalis, whereas superficial inguinal ring is a defect in your external oblique aponeurosis. The content is your vas deferens and the ilioinguinal nerve. Right. Now, when you talk about indirect inguinal hernia, in the indirect inguinal hernia, the entry is from the deep ring. The exit is from the superficial inguinal ring. In a direct inguinal hernia, the entry is from the posterior aspect of the Hasselbalch triangle, and the exit is through the superficial inguinal ring. So, on a quick recap, what is the entry of indirect inguinal hernia? It is going to be your deep inguinal ring, whereas here it is going to be your Hasselbalch triangle. I hope everybody knows the triangular boundaries of the Hasselbalch triangle. Okay. Now, in terms of Hasselbalch triangle, this is the boundary. This is going to be the lateral border. It is formed by the lateral border of rectus abdominis muscle. The medial boundary, it is formed by the inferior epigastric artery, and inferior boundary, it is formed by the inguinal canal. It is formed the inguinal canal. So Hasselbalch triangle, that area, this triangular area is what we call it as the Hasselbalch triangle. That is the area of weakness. Okay. Exit for both of them is going to be your superficial inguinal ring. The sac in the direct inguinal hernia is made up of peritoneum, whereas sac in the direct inguinal hernia is made up of fascia transversalis. It is formed by the fascia transversalis. The content here can be bowel or omentum. The same thing can be validated here. It can also have bowel or omentum. It is the bowel or omentum. What is the relationship of the sac and the cord? So when the sac comes out, you will notice when the sac is going to come out, this is the peritoneal sac. It is going to travel along like this, and this is how the sac will come. From here, when the sac comes, it will come along with the fascia transversalis. So the fascia transversalis will also exit from here. This is how the sac will come. Okay. So when you talk about the relationship of the sac with respect to the cord, right? In the indirect inguinal hernia, the cord is medial to the sac, whereas here in direct inguinal hernia, the cord is lateral to the sac, and that is what I'm trying to tell you. Relationship of the cord, sac, and the cord. Remember, in the indirect inguinal hernia, the sac lies, you can see here, lateral to the cord. Whereas here in direct inguinal hernia, the sac lies medial to the cord. It lies medial to the cord. What is the relationship of the neck and the inferior epigastric artery? That is nothing but entry point. You will see here the neck lies lateral to inferior epigastric artery. Here you will see the neck lies medial to inferior epigastric artery. Right? The risk for strangulation is high for indirect and low for direct inguinal hernia. It is low for the direct inguinal hernia. Okay. Now, in a quick succession, what you talk about the clinical features of your inguinal hernia? The patient will present to you with inguino-scrotal swelling. The patient is going to present to you with inguino-scrotal swelling. But a direct inguinal hernia, it is from the Hasselbalch triangle. This is the area. This is the area from where it is going to enter. So this triangular area. Okay. This triangular area is what we call it as the Hasselbalch triangle. Yep. So here it is inguino-scrotal swelling. Patient is going to present. For most important, it is going to be a reducible swelling. It is a reducible swelling. It will have a positive cough impulse. It is going to have a positive cough impulse. You cannot get above the swelling. You cannot get above the swelling. You cannot get above the swelling. And remember, testes remains palpable. Testes remains palpable. Okay. Now, how do you differentiate between a direct and an indirect inguinal hernia? That is by ring occlusion test. In the ring occlusion test, first step, it is to reduce hernia. After you have reduced the hernia, the step number 2, it is to occlude deep inguinal ring. After you have occluded deep inguinal ring, ask the patient to cough. Ask the patient to cough. So once the patient coughs, I have two possibilities. One, the cough impulse is positive. Another, the cough impulse is negative. If the cough impulse is positive, then it is your direct inguinal hernia. If it is negative, then it is going to be indirect inguinal hernia. Either way, the ring occlusion test. The ring occlusion test is going to tell you whether you're looking at a direct or indirect inguinal hernia, right? Now, somebody is asking, what do you mean by you cannot get above the swelling? It's very simple. When you palpate a swelling, if this is swelling, you start from one end, you go to the maximum height, and then you travel along. Okay. So if you're able to palpate the swelling till its highest point, and then you go back, so you're able to palpate the entire surface, it is because you're getting above the swelling. Now, in a hernia, what is going to happen? This is the abdominal wall. Now, through the abdominal wall, there is a defect that is present, and through this defect, you see the hernia is going to protrude out. If you say this is the defect that you're saying, and through this defect, this is the hernia that is popping out, right? So when you look at this is how you're going to present. So when you start palpating it, you go to the top, but you're not able to go further because the abdominal wall is stopping, because the other end of the swelling is inside the abdominal wall. I start palpating, I reach to the top, but I cannot get on the other end. That means the other half of the swelling is beyond your reach, or it is intra-abdominal. Hence, it is called as you cannot get above the swelling. Okay? Now, in terms of investigation, remember, clinical examination is the investigation of choice. Inguinal hernia is a clinical diagnosis. Now, you talk about hernia repair. All that you have to know is names of the open repair. You have Bassani, Shouldes, Dasada, and Malinois. These are your tissue repairs. These are your tissue repairs. Lichtenstein is going to be your mesh repair. It is your mesh repair. So all these are called as herniorrhaphy. That is a tissue repairs. Mesh is used. It will be called as hernioplasty. Usage of mesh, it is called as hernioplasty. Okay. So only tissue repair is herniorrhaphy. Involvement of mesh will be called as hernioplasty. So what is the surgery of choice? It is your Lichtenstein tension-free mesh repair. It is your Lichtenstein tension-free mesh repair. Okay. So these are with respect to your open hernia repair. So the three terms, which is what is herniotomy, what is herniorrhaphy, what is hernioplasty. Herniotomy is done for indirect inguinal hernia, where you open the sac, reduce the content, and plicate the redundant sac. And plicate redundant, that is excessive sac. This is called as herniotomy. Herniorrhaphy, it is to repair the defect. Hernioplasty, it is your mesh placement. Right? So in a hernioplasty, we will do herniotomy. We will do herniorrhaphy. And then I will place a mesh. This is your hernioplasty. Okay. Herniorrhaphy is done for direct inguinal hernia. If you're only doing herniorrhaphy, that's for direct inguinal hernia. If you're doing that is mesh placement, the mesh placement can be done in both direct inguinal hernia as well as indirect inguinal hernia. But remember, in direct inguinal hernia, herniotomy is not done. Because in herniotomy, the sac has to be opened, and sac in direct inguinal hernia is made up of fascia transversalis, which is a part of abdominal wall. In direct inguinal hernia, herniotomy is not done. Herniotomy is not done. All right. Now, in your talking about laparoscopic repair, you have two options. That is your TEP, that is total extraperitoneal repair. Another one that you have is what we call it as TAPP, that is your trans-abdominal preperitoneal repair. It is your trans-abdominal preperitoneal repair. Trans-abdominal preperitoneal repair. Now, in the laparoscopic inguinal anatomy, there are three triangles that you need to know. Okay, we'll talk about all these triangles. Number one is the triangle of Doom. Number two, it is the triangle of pain. And number three, it is the crown of death, also called as corona mortis. Also referred to as the corona mortis. Now, what are the components that makes the triangle of doom? You take this as a representation of the abdominal wall. We're talking about this is the representation of the fascia transversalis. Just for the sake of understanding, let's say this happens to be the midline. Now imagine that this is the peritoneal reflection. So this is the peritoneal reflection that we have brought it down. Okay. Now, when you talk about the deep inguinal ring, when you talk about the deep inguinal ring, let's say this is the objective of the deep inguinal ring that is present. So this is going to be your superficial inguinal ring. You will notice that the vast difference which is going to come, it is going to enter the deep inguinal ring, it is going to turn medial. And either sense, when the vas is entering, it is going to turn medially. So this is the vast difference which is present. Laterally, you will see there's a blood vessel. This is your gonadal vessel, which is present on the either side. Okay. Now, within this gonadal vessels, you will notice that there is presence of the external iliac vein that is present and the external iliac artery. So this is your gonadal vessel. So you see this triangular area, which is present between the gonadal vessels, peritoneum, and your vas deferens is called as triangle of doom. So when you talk about the boundaries of the triangle of doom, this is the medial boundary, this is the lateral boundary, this is the inferior boundary. The medial boundary is formed by the vas deferens. The lateral boundary is formed by your gonadal vessel. And your inferior boundary is formed by peritoneum. It is formed by peritoneum, right? This is your triangle of doom. Why do we call it as triangle of doom? Because the content that you see here, it is your external iliac vein and the external iliac artery. It is your external iliac vein and the external iliac artery. These form the content. So injury in this area is a certain death of the patient. So it is called as the triangle of doom. It is called as the triangle of doom. So when you look at the triangle of pain, it will have the same orientation. It's slightly different. This is the abdominal wall. Let's say this is the outer surface that we're talking about. This is the fascia transversalis. Let's say this is the peritoneal reflection that you have gotten down. Let's say this happens to be the midline. This is the deep inguinal ring that is present. So let's say we're talking about the vast difference which is here. You have the gonadal vessel which is present here, right? So this area between the iliopubic tract, the peritoneum and the gonadal vessel is what we call it as the triangle of pain. So triangle of pain, this is the medial boundary, this is the inferior boundary, this is the lateral boundary. Now the medial boundary is formed by the gonadal vessel, which was the lateral boundary of the triangle of doom. Inferiorly, it is formed by the peritoneal reflection, and laterally, it is formed by the iliopubic tract. Now, what does triangle of pain consist of? It consists of multiple nerves that are passing through. Remember, the most common nerve injury, the most common nerve damage in laparoscopic hernia repair. In the laparoscopic hernia repair, it is the lateral cutaneous nerve of thigh. This is the lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh. Okay. So it's a triangle of pain. Remember, triangle of pain with triangle of doom. Triangle of pain with triangle of doom. It is what we call it as the trapezoid of disaster. This is what we call it as a trapezoid of disaster. This is what we call it as a trapezoid of disaster. Okay? Now, in terms of crown of death or the corona mortis. So what is crown of death or the corona mortis? You take this as a representation of the anterior superior iliac spine, this is the pubic tubercle, this is the pubic symphysis, and this is the pubic arch, right? Now, what happens is when you look at the blood vessel, let's say this happens to be the aorta which is present, which is traveling around. This is the bifurcation that is present, that is common iliac. It goes into the external iliac, which is traveling like this. And then you have the internal iliac, which is going across, right? So two blood vessels that are going to originate. One is going to be your inferior epigastric artery, which is arising from the external iliac artery. And one more is your obturator artery. It is your obturator artery that is arising from the internal iliac vessel. Now, what happens is there is an abnormal communication. So we look at this. There is an abnormal communication between the obturator artery and the inferior epigastric artery. Now, this abnormal communication over the pubic arch is what we call it as the corona mortis, because when you're fixing the mesh to a pubic arch, you have to pin your mesh to the pubic arch and you can cause damage to this blood vessel. So it is an abnormal connection between the inferior epigastric artery and the obturator artery. This is your internal iliac artery. This is your external iliac artery. And this is your aberrant blood vessel. So this happens to be our aberrant blood vessel. Or it's an aberrant communication. It is an aberrant communication between inferior epigastric artery and the obturator artery. And this is what we call it as the corona mortis. This is what we call it as the corona mortis. Okay? So each and every triangular component is going to be absolutely important. Okay? Clear? So this is with respect to laparoscopic inguinal hernias anatomy. Now, the same thing here, if you see the triangle of doom, just for the sake of understanding, this happens to be your deep inguinal ring. You see, this is the medial side because the pubic component is here. So on the medial side, when you see this is going to be your vas deferens. On the lateral side, you see, this is your gonadal vessel. This is going to be your gonadal vessel. And this area is what we call it as the triangle of doom. This is your triangle of doom. So in this area, if you injure, because injury of external iliac artery and external iliac vein. Now, in terms of mesh, what are the materials which are available? Remember, the commonly used materials are proline. It could be polyester and a composite. Composite is a combination of two different elements. Remember, proline is the most commonly used. Ideal characteristic of mesh has been our exam question. Now, when you talk about ideal characteristic of mesh, it should be hydrophobic. It should repel water. It should be hydrophobic. It should have large pore macro porous. It should have light weight. It should have light weight. Weight is less than 40 grams per meter square. Right? So it should be hydrophobic. It should have macro porous. It should have light weight. It should have lightweight. Okay. So these are the ideal characteristic of mesh. What is the ideal overlap? Remember when you talk about the defect, so this is a defect, this is the mesh overlap. The ideal overlap, should be 5 centimeters anyway. Minimum overlap, this is your minimum overlap. Remember, the minimum overlap should be of 2 centimeters. It should have 2 centimeters. Remember, there's around approximately 50%, there will be approximately 50% mesh shrinkage is noticed. Approximately 50% of mesh shrinkage is noticed. This is your proline mesh. which is white in color. Now, if you have a glistering surface, shiny surface on one end and mesh on the other end, this is what we call it as the composite mesh. This is what we call it as the composite mesh. Okay. So these are the various characteristics of the mesh that are present. See? Okay. Rest are not important. We have already dealt with that. So this was a small mistake. The whole chapter of hernia went into the document. Only the inguinal hernia part was important. So I'm just removing it. Yeah. So we can discuss between the omphalocele and the gastrocesis. That is again an abdominal wall defects. Okay. Beta, you don't need to remember or read the entire hernia. Indirect, I mean, inguinal hernias are the most important from the exam perspective. That is what you're going to see across. Remember, the only difference between omphalocele or visible difference is there is presence of a membrane. If there is presence of a membrane, then it is going to be omphalocele. If the bowel is directly visible, if there is a visible bowel, then we say it is going to be gastrocesis. Okay? Now, when you look at the important aspects, so remember it is a central abdominal wall defect, that is omphalocele, whereas gastrocesis is always right to the umbilicus. Defect of the omphalocele is more than 4 centimeters. It is usually around 4 centimeters here. Omphalocele is associated with Beckman-Wiedemann syndrome and cardiac abnormalities. Here it is only associated with intestinal atresia. The management here, it is to reduce the content and repair the defect. Reduce content and repair defect. The same is validated for your gastrocesis as well. Okay. So these are the, ये आपका last to last session का FMG question था. So difference between omphalocele and gastrocesis we discuss almost every time. Somebody is asking about the mesh trapments. अच्छा ये याद रख लो. Most common nerve injury. Most common nerve injury in open inguinal hernia repair. In the open inguinal hernia repair, it is going to be your ilioinguinal nerve. It is going to be your ilioinguinal nerve. Whereas, which is the most common nerve getting trapped? What is the most common nerve getting trapped in mesh of inguinal hernia repair? Answer is the iliohypogastric nerve. It is the iliohypogastric nerve, and this will result in chronic inguinal pain. It will result in chronic inguinal pain, also called as inguinodynia. Okay? So this is the carry home message that you should need to know. So lateral cutaneous nerve of thigh is going to be in the laparoscopic surgery. Open में it is going to be an ilioinguinal nerve. ठीक है? चलो. So this is with respect to hernia. So we concluded our entire discussion on general surgery. So far, any questions, guys? Quick feedback. So far, any questions? Quick feedback. कोई सवाल, कोई शक? टी ब्रेक इतनी जल्दी? ये ईसोफेगस कंप्लीट कर ले या ज्यादा हो जाएगा? Let me see, 15 minutes I can complete any small topic. The images are there, Euro images as well. But breast cancer staging is important. We have told in the class multiple times. So I have told that staging, breast cancer is the only staging that you have to remember completely. None of them are important completely. Just as thyroid में बताया था, सिर्फ T staging is important. That is more than enough. ठीक है. अच्छा, we'll talk about esophagus को थोड़ा complete कर लेते हैं. 15 मिनट के बाद फिर चलते हैं. बेटा क्लास एंडिंग टाइम अगर आप पूछोगे, वी हैव फिनिश्ड 50 पेजेस, वी हैव टू गो 100 पेजेस मोर. ठीक है, तो 100 पेजेस में अगर आप लगा लो, अभी 5 बज रहा है. ठीक है, वी स्टार्टेड एट अराउंड 12:30. अगर आप 1 घंटे का ब्रेक निकाल दोगे, 1:30, 2:30, 3:30, 4:30, 3 घंटे में 50 हुआ है. ठीक है, अनदर 3 घंटे में एक और 50 होगा, तो मतलब 8 बज जाएगा. फिर जो लास्ट 50 रहेगा, दैट विल बी अनदर 3 आवर्स. तो ठीक है, अराउंड 10 o'clock, 10:30 तक आज हो जाएगा. चलो, we'll try to wrap it up also. और थोड़ा we'll try to थोड़ा भगाने की कोशिश करेंगे, लेकिन करा देंगे. चलो, so we'll talk about the tracheoesophageal fistula. The pathogenesis, magic word याद रखिए ना. It is because of incomplete. It is because of incomplete or improper septation of foregut. Of the foregut. Okay. So when you see this is the foregut that is present, this is the septa that we are talking about. Now, because of this, you see the anteriorly it will form respiratory bud, posteriorly it will form esophagus. If that does not occur as planned, it will result in tracheoesophageal fistula and atresia. Now, there are following varieties. You have the type A variety. This is type B, this is type C, this is type D, and this is your H variety. Remember, in type A variety, it is only having atresia. Type B, there is atresia with upper communicating fistula. Type C, atresia with lower communicating fistula. Type D, atresia with both upper as well as lower communicating fistula. H variety is only fistula. There is no atresia. Remember, the overall most common type. The most common type is going to be your type C variety. It is going to be a type C variety where you have atresia with lower communicating tracheoesophageal fistula. So it is type C is described as, it is esophageal atresia. It is the esophageal atresia with lower segment. Is it lower segment or the lower communicating fistula? Lower communicating tracheoesophageal fistula. Okay. Now the clinical features are very simple. Number one, it will be a day 0 or day 1 of life. It is slightly more common in male child when compared to female. Because there is no further passage, there will be repeated regurgitation. There is repeated regurgitation of all feeds. That is one of the most characteristic feature. Along with repeated regurgitation, there is continuous drooling of saliva. There is continuous drooling of saliva that is noticed. And because every time the baby is fed, it can aspirate, and that aspiration will result in coughing. There's coughing and cyanosis. There's coughing and cyanosis during feeding. There is coughing and cyanosis during feeding. Sorry. There is coughing and cyanosis during feeding, and more importantly, it can also result in lung abscess secondary to aspiration. It can result in secondary to aspiration. More importantly, there will be presence of abdominal distension as well. The reason for abdominal distension is the air that the patient is breathing. That air via the fistula will go into the stomach and then gets filled up. This we all know. Now, when you talk about the investigation, the first investigation would be an X-ray with the nasogastric tube in situ, and the finding there'll be presence of coiling of nasogastric tube. Now, the purpose of putting the nasogastric tube was not to make a diagnosis, but to prevent the saliva or any other content to get aspirated. So the NG tube was put for to prevent aspiration. The investigation of choice, it is going to be your contrast imaging. Now, when I say contrast imaging, that is like we'll give a contrast for the baby to swallow and take an X-ray. Remember, the most common and safest contrast is going to be iohexol. This is the contrast given. You confirm the diagnosis, but you also know that this tracheoesophageal fistula is associated with other congenital abnormalities, can be remembered as ventral mnemonic. Now, in the ventral mnemonic, V stands for vertebral body defect. It is the vertebral body defect. A stands for anal atresia. A stands for anal atresia. C stands for cardiovascular abnormality. That is your patent ductus arteriosus and the ventricular septal defect. T stands for tracheoesophageal fistula. It is your tracheoesophageal fistula. R stands for renal abnormalities. Example like horseshoe kidney and renal agenesis. It is a renal agenesis. L stands for limb abnormality, that is associated with radial hypoplasia. It is associated with radial hypoplasia. Okay. Now for the surgery, remember the approach is important. That is your previous exam question. How would you approach it? It is going to be your right thoracotomy. We normally say we have two components. One is what we call it as the short distance atresia. Another one that you have is what we call it as the long distance atresia. One is a short distance atresia, another is long distance atresia. The criteria is the distance between the two atresial segments. If it is less than 2 vertebral distance, it is called a short distance. And the distance between the two atresial segment is more than 2 vertebral distance, long distance atresia. If it's a short distance atresia, then you have to go ahead with primary repair. You excise the fistula and make an anastomosis. Whereas it's a long distance atresia, you will do. So I would ligate the tracheoesophageal fistula and do a feeding jejunostomy. I'll do a feeding jejunostomy and then wait for 6 months. After 6 months, if the distance is less than 2 vertebral, then I would go with the primary repair. If it is more than 2 vertebral distance, if it is still more than 2 vertebral distance, then I would do a interposition surgery. I will take a loop of intestine and position between the two segments which are present. So if they ask you, these are your previous exam questions. What are the questions? Which limb of atresia is mobilized to make the anastomosis? Is it the upper limb or the lower limb? Will you pull the upper limb down or would you take the lower limb up? So normally we say it is lower limb taken up. That is wrong. It is the upper limb of the atresia which is mobilized. What is the wait period for long distance atresia? We just discussed it is 6 months. What is the ideal conduit? It is going to be colon for interposition, left preferred over right. The other conduits are jejunum, which is most common conduit in children. And the other one is going to be stomach. And this happens to be the most common conduit in adults. It is the most common conduit in adults. Okay? Very good. What is the most common complication? Remember, it is going to be GERD after the surgery. Okay? So the data in red has been a previous exam question. Clear? Sure. So grades of dysphagia, this has been our NEET PG exam. So quickly talking about grade 1, the patient eats normally. Grade 2 requires liquid to swallow. Requires liquid to swallow solid feeds. Grade 3, only semi-solid feeds are taken. Here it is only liquids. Grade 5, only saliva is able to pass. And the last one, that is grade 6, not even saliva. Grade 6, not even saliva will be able to be pushed across. So, now, congenital diaphragmatic hernia, a quick recap. We have the Bosch-Talek hernia. In the Bosch-Talek hernia, where do you see the defect? The defect in the Bosch-Talek hernia. If I divide this entire context, this will become anterior, this will become posterior. If I draw in the center, this is going to be the right, sorry, this is going to be the left and this is going to be right. So defect is present on the left-sided. It is left-sided. Posterolateral side. It is going to be left side, posterolateral side. On the other hand, when you say the Morgagnian hernia is defect, this is the midline, this is here. So this is left, this is right, this is anterior, this is posterior. So the defect in the Morgagnian hernia, is right-sided. It is the right-sided anteromedial defect. It is the right-sided anteromedial defect. Okay. Now, remember 90% of your congenital diaphragmatic hernias are Bosch-Talek, only 10% of them are Morgagnian. So hence diaphragmatic Bosch-Talek is more important. Now, if they ask you what is the most common organ to herniate for Bosch-Talek, it is stomach, spleen, followed by transverse colon. Whereas in terms of Morgagnian hernia, the most common organ to herniate. The most common organ to herniate, it is your transverse colon. It is your transverse colon. Okay. Now, age of presentation for Bosch-Talek is day 0, day 1. They present to you with a classical triad of RDS. There is presence of respiratory distress. We all know that respiratory distress is because of pulmonary hypoplasia. You see here, the lung is underdeveloped. So the pulmonary hypoplasia. So it is because of pulmonary hypoplasia. The heart is pushed on the other side. There is dextrocardia. And as the stomach is pushed up, the abdomen dips in. And that is what we call it as the scaphoid abdomen. So respiratory distress, dextrocardia, and scaphoid abdomen is noticed. Remember, bag and mask ventilation is contraindicated. The bag and mask ventilation. In stomach, there'll be over distension of the stomach. And when the stomach gets over distended, you can see in the image, it is already indenting onto the lung. It will cause further compromise of the lung. And at the same time, excessive amount of air, when it goes into the lung, it will cause barotrauma as well. Two reasons: overinflation of the stomach causing more compression on the lungs and also cause barotrauma. So two conditions why we say it is contraindicated. So if I say what is the first investigation? The first investigation would be an X-ray. So in the X-ray, there'll be presence of, see, there's a massive air bubble in the thoracic cavity. So there's presence of massive air bubble in left hemithorax. Second, you can see the lung shadow is almost getting diminished. So this is what we call it as the pulmonary hypoplasia. It is a pulmonary hypoplasia. Heart is shifted on the other end, and this is what we call it as the dextrocardia. This is going to be dextrocardia. Okay, so three findings that you'll see on an X-ray. But if I say what is the investigation of choice, then it is going to be CT thorax. It is going to be CT. Management is pretty straightforward. It is to bring back the content. bring back the content with repair the defect. Now, to prevent any further invagination, you have to perform gastropexy, that is fixation of the stomach, not allowing the stomach to invaginate back. Now, the two complications, one, it is going to be your pulmonary hypoplasia. One, it is your pulmonary hypoplasia. Another one is going to be your pulmonary hypertension. I have already given you the objective of pulmonary hypertension because the lung volume is lesser. The blood that is coming from the right ventricle, as it ejects out, it goes into right lung as well as left lung. The right lung has enough space, it is fine. Left lung does not have enough amount of space. The blood is pushed back onto the pulmonary vessel and the pressure in the pulmonary vein will increase. To compensate that pressure, there will be right-sided cardiac remodeling resulting in right ventricular hypertrophy, which will result in cardiac failure as well. If I say what is the most common cause of death in a patient of Boston hernia, it is the pulmonary hypoplasia, which is the overall most common cause of death in a patient of Boston hernia. Pulmonary hypertension will take 10 years. So the next peak of mortality comes at the age of 10. So this is with respect to Boston hernia. But the lung will compensate. When you reduce the stomach, that lung that has been hypoplastic over a period of time, it's like a balloon. No, it will keep on stretching. It will compensate, but it will not become normal, but it will be good enough for the patient to survive. So don't worry about it. Okay. So this is with respect to your Bosch-Talek hernia. So we'll talk about GRD. By definition, GRD is nothing but pathological reflux. It is a pathological reflux of gastric content into esophagus. Into the esophagus. What is the etiology for your GRD? Remember, it could be n number of reasons, but the most important reason is if there is decrease in tone. There is decrease in tone of the lower esophageal sphincter, as simple as that. Okay? Now, what are the causes? Number one, the most important cause is going to be smoking. So whenever you smoke, one hand you have a cigarette, another hand you have coffee. So caffeine is another important component. To hide the smell of the smoke, you will consume chocolate. Going back home, you want to relax, you will take alcohol. Next day morning, there is hangover, you will take drugs. Drugs that decrease the tone of LES can be remembered as the ABCD drugs. A is your anticholinergic. B stands for barbiturates. C stands for calcium channel blocker. And D stands for diazepam. D stands for diazepam. So what are the other risk factors that you have? Smoking not only decreases the tone, but also aggravates or adds as a risk factor for GRD. Apart from that, it is associated with obesity. It is associated with pregnancy. Connective tissue disorders like scleroderma. Connective tissue disorders like scleroderma are the important risk factors. Okay. Everybody knows all the risk factors. What is the clinical scenario that you will see? The first symptom as the acid refluxes. It falls onto the squamous epithelium, it burns. So there is sudden severe onset. There is sudden severe onset of retrosternal. There is this retrosternal heartburn. Now, as the tone is getting laxed, there will be regurgitation of food particles. There is regurgitation of food particles. Injury to the esophagus will result in a referred pain in the epigastric region. So there will be presence of epigastric pain. There is presence of epigastric pain is also noticed. So sudden severe onset of retrosternal heartburn, there's regurgitation of food particles, there's presence of epigastric pain is also noticed. Now, as the reflux becomes more and more progressive, it will come to the tongue, patient will be able to taste it. So the presence of sour brash is present. It goes onto the teeth, destroys the teeth, and hence resulting in damage of your protective cover, that is resulting in yellowing of teeth. It will result in yellowing of teeth. Now, as it can also result in aspiration. Aspiration can result in cough or asthma-like features. Or it can result in asthma-like symptoms. Okay. So these are coughing and asthma-like symptoms are non-GI symptoms. Okay. This was your this year's INI-CT question, which is a non-GI symptom of GRD. It is coughing and asthma-like symptoms. See? Now, what are the complications of GRD? It can be esophagitis, shortening of the length, hiatal hernia. It is usually your sliding hiatal hernia. It can result in stricture as well as Barrett's esophagus. Remember, Barrett's esophagus it will have presence of intestinal type of metaplasia. It will have intestinal type of metaplasia. We call it as intestinal metaplasia because here the squamous epithelial cell converts into columnar epithelial cells with presence of goblet cells. And presence of goblet cells is a characteristic presentation of intestinal type of mucosa. Goblet cells produces what? They produce mucin. Now, remember, because of this intestinal metaplasia, it increases the risk for adenocarcinoma of esophagus. It increases the risk for adenocarcinoma of esophagus. On an upper GI endoscopy, you'll see presence of red velvety mucosa, which is the characteristic feature. So hence the investigation of choice is going to be an upper GI endoscopy with biopsy. Biopsy is done to rule out the malignancy. Management for Barrett's esophagus, it is always to treat GRD because Barrett's is not a disease. It's a presentation of an underlying disease. So you cannot treat Barrett's without treating the GRD. Remember, on an upper GI endoscopy, if this length, this is your red velvety mucosa. If the length of the red velvety mucosa is more than 3 centimeters, it is what we call it as the classical Barrett's. If it is less than 3 centimeters, it is called a short segment Barrett's. If it is less than 3 centimeters, it is called as the short segment Barrett's. This is what we call it as the short segment Barrett's. So this is with respect to the complications which are associated with GRD. Okay. Now, how do you investigate GRD? Currently, the investigation of choice is going to be your 24 hours pH monitoring. There are two sensors, your esophageal sensor and the gastric sensor or a stomach sensor. Remember, from the gastroesophageal junction, they are placed 5 centimeter above and 5 centimeter below the G junction. That is the placement for your sensors. The PPI must be stopped 2 weeks prior to the investigation. Now, whenever a patient is diagnosed with GRD, the first line management is always a medical management, that is a lifestyle modification with PPI for 8 weeks and small frequent feeds. If that does not work out, surgical management indication is important. Currently, if it is not responding to medical management, presence of Barrett's esophagus, stricture, hiatus hernia, or suspicious of malignancy. If any one of them are present, we'll go with surgery. The surgery is what we call it as the anti-reflux surgery. Now, in the anti-reflux surgery, we will do fundoplication. Now, there are 4 examples of fundoplication that we should be knowing it. Number 1 is your Nissen's, then you have Dor and Topeta. Nissen's, remember, it is a complete fundoplication, or we can say it's a posterior complete fundoplication. It is a posterior complete fundoplication. So why I'm saying it is posterior, because the fundus is brought behind the stomach, complete because it is sutured from where it is begin. Whereas stopit is also posterior, but this time it is not completely sutured, it is partial fundoplication. It is your posterior partial fundoplication. On the hand, this is anterior partial fundoplication. It is your anterior partial fundoplication. So Nielsen's is also called as 360 degrees posterior fundoplication. It is also called as 360 degrees posterior fundoplication. So this is with respect to GRD that you should know. GRD is a very, very important topic. You cannot miss going across here. एक और याद रख लें, just for the sake additional note point. There's something called as D-Meester score. If the D-Meester score is more than or equal to 14.7, it is confirmatory of GRD. Don't worry about what is the D-Meester score. Just remember this number. A score of more than or equal to 14.7 is what we call it as a confirmatory component for GRD. Okay? So this is with respect to GRD and now important topic. Okay? Chalo, okay. Let's take a tea break here. 15 minutes. We'll resume back. Okay? Chalo. Yeah, chai break or tea break or a coffee break, whatever. We'll resume back. It is 5:15 on my clock. 5:30 we'll resume back. Chalo. All right, can we start? I got a bit late because of some work related issues. वीकडे है, मैनेज करना थोड़ा मुश्किल हो जाता है, मतलब ट्राई। ठीक है, चलो, कैन वी स्टार्ट? Quick feedback. Okay, chalo. So we talk about motility disorders in the esophagus. Again, a very important topic from the exam perspective. We have two, that is achalasia cardia and diffuse esophageal spasm. If I say what is the etiology for achalasia cardia? Achalasia cardia, there is because it is progressive loss. There is this progressive loss of inhibitory neurons. There is progressive loss of inhibitory neurons in the lower one-third of the esophagus. It is lower one-third of the esophagus. Diffuse esophageal spasm is because of repeated non-progressive. It is a repetitive non-progressive sustained contractions in esophagus. Sustained contractions of esophagus. So it is repeated non-progressive sustained contractions of the esophagus. Beta, investigational choice for GRD is 24 hours pH monitoring. Right? Give me 1 second. I have got one call from the colleague. Just hold on for a second. Hello. Sorry. Okay. Better investigation choice for GRD is 24 hours pH monitoring. Gold standard is impedance pH monitoring. So that is impedance pH monitoring. It's not for GRD, we don't need an upper GI endoscopy, no? Okay. Now, what is the cause for the achalasia cardia? Remember, the most common cause is going to be idiopathic. Idiopathic happens to be the most common cause. If this is not there, the second best is going to be Trypanosoma crucis infestation. Here also the cause most commonly is going to be idiopathic. It is going to be idiopathic. Now, in a clinical presentation, achalasia cardia is more commonly seen in females when compared to males. The usual age of presentation is between 50 to 60 years old female, right? Now, both of them, because there is lower inhibitory neurons are lost, basically there's failure of relaxation of lower esophageal sphincter. The magic word to remember here, there is failure of relaxation. There is failure of relaxation of lower esophageal sphincter. There's failure of relaxation of the lower esophageal sphincter. So here the patient is going to present to you with dysphagia. Here the patient will present to you with dysphagia. Remember the most important feature of dysphagia here. Here dysphagia will be for both solids and liquids. The characteristic feature here, dysphagia is more for liquids when compared to solids. And this is going to be a progressive dysphagia. This is going to be a progressive dysphagia. So dysphagia for both solids and liquids more when compared to solids, and it is going to be a progressive dysphagia. It is going to be a progressive dysphagia. Along with that, it is associated with aspiration pneumonia. It is associated with the aspirational pneumonia. Because of the difficulty in swallowing, it will have poor appetite. So appetite in these patients are going to drop down significantly. And this will be associated with weight loss. When you talk about diffuse esophageal spasm, for the diffuse esophageal spasm in terms of clinical presentation, this is also more commonly seen in females when compared to males. It is usually seen between 30 to 50 years of age. Now, diffuse esophageal spasm has two problems. There will be sudden severe onset of retrosternal chest pain. There is sudden severe onset of retrosternal chest pain. There is sudden severe onset of retrosternal chest pain. The pain is so severe that it is also commonly known as esophageal angina. Is also referred to as the esophageal angina. The pain is so severe that it is referred to as the esophageal angina. Okay. I'll tell you better. Everything we'll talk about when do you call it as nutcracker, every single component will be done. But this is your esophageal angina. Along with that, the patient is going to have dysphagia as we run across our questionnaire. Here, dysphagia will be for both solids and liquids. It will be for both solids and liquids. It will be equal for both solids as well as liquids. They have equal for solids and liquids, and this is going to be non-progressive. This is going to be non-progressive dysphagia. Okay. Now, when you talk about the investigation, remember the first investigation is going to be barium swallow. You can see the finding that you see in the barium swallow here, clearly demarcated, which is here. So the barium swallow findings is going to be number one. This will be your bird beak sign. This would be your pencil tip sign. Bird beak sign is there, pencil tip sign is there. Along with that, you can also call it as rat tail appearance. But if I say what is the investigation of choice for all motility disorders of esophagus, it is going to be manometry. It is going to be the manometry. And remember, in manometry, the integrated relaxation pressure, IRP of more than or equal to 15 millimeters of mercury with 100% failed peristalsis. With 100% failed peristalsis is the criteria for your achalasia cardia. So when you do a barium swallow, that is for diffuse esophageal spasm, when we perform a barium swallow, you can see a very characteristic image that is present. You can like this, like a corkscrew appearance or a wavy margin, that is your rosary bed appearance, right? So on a barium swallow, you will see presence of corkscrew appearance. There is going to be a rosary bed appearance. This will present to you as pseudo-diverticulum. This will present to you as pseudo-diverticulum and beaded appearance, as well as the beaded appearance, right? Again, when you talk about it in terms of investigation of choice is going to be manometry. So in the manometry, we'll measure something called as DCI, right? If the distal contractile integral is more than 400 millimeters of mercury, this is called as diffuse esophageal spasm. But same if it is more than 8,000 millimeters of mercury, this is called as the nutcracker esophagus. This is what we call it as the nutcracker esophagus. Okay. How do you like to manage it? Remember, the first line management is going to be a medical management. We'll give calcium channel blockers, we'll give nitrates. If not, then we will give injections of botulinum toxin. Injections of botulinum toxin. The same is also given for diffuse esophageal spasm. If not, the second line, if medical management fails, it is going to be surgery. Surgery of choice here is going to be Heller's cardiomyotomy. It is your Heller's cardiomyotomy. Whereas the second line for diffuse esophageal spasm is your long esophageal myotomy. It is your long esophageal myotomy. Okay? Absolutely correct. Endoscopic management, we have something called as POEM. POEM stands for per oral endoscopic myotomy. It is your per oral endoscopic myotomy is the POEM, right? There's no endoscopic management for here. You can do POEM here in the basic objective. Okay? So these are the motility disorders that you should be knowing across here, right? Now, every time in the exam, to make your life difficult, one of the most commonly asked components is going to be with respect to dysphagia, right? So we need to understand that how do you characterize or how do you cater the questions that are going to be asked on dysphagia. So I have a small table for you, that is how do you categorize a particular form of dysphagia, and based upon how it is going to present, we are going to talk about its management, right? Now, let's say you have a patient who's having dysphagia, and that dysphagia is for solids and liquids. It is progressive in nature. And if the presenting symptom is of heartburn, please do not answer as GRD, because GRD may stricture ki wajah se there will be dysphagia only for solids, not for liquids. So this is your progressive systemic sclerosis. This is your progressive systemic sclerosis. Progressive systemic sclerosis. On the other hand, if patient develops a pulmonary symptoms, that is of lung abscess, then this is your achalasia cardia. This is going to be your achalasia cardia. On the other hand, dysphagia for both solids and liquids, but non-progressive in nature, and the patient's presenting symptom is of severe chest pain. We just learned the answer here is going to be diffuse esophageal spasm. The answer here is going to be diffuse esophageal spasm. Now, dysphagia only for solids, but it is progressive in nature if the presenting symptom is of weight loss. If the presenting symptom is of weight loss, then it is esophageal carcinoma. It is the esophageal carcinoma. On the other hand, if the symptom is of heartburn, presenting symptom is of heartburn, then it is because of peptic stricture. Dysphagia of solids, and it is non-progressive. That means there is going to be a mechanical obstruction, and that is going to be because irrespective of whatever symptom, it is usually seen in lower esophageal ring, right? Very good. The lower esophageal ring is also called as the Schatzki's ring, right? ये जो table है, to solve any question on dysphagia, this is the most important point or the thing that you have to consider. Once you have this sorted, any question on dysphagia, you will be able to answer without having any difficulty at all. Now, in a diverticular disorder, we talk about the Zenker's diverticulum. Now, remember Zenker's diverticulum, when you talk about it, number one, it is an example of a false diverticulum. It is an example of a false diverticulum. This is a posterior diverticulum. It is a posterior diverticulum. All the important words I'm listing out. False posterior. It is a pulsion diverticulum. It's a pulsion diverticulum. This is seen in the cervical regions. It is called as the cervical diverticulum. And this is usually left-sided. This is usually left-sided. Okay. Now remember the rest of them. That is your mid-esophageal and the epiphrenic. These are right-sided. That is the only thing that you have to remember with respect to these two. Okay. Now, when you talk about the Zenker's diverticulum, three important prerequisites. The age has to be more. So age is seen in age about 50 years. The second thing that you will see is presence of an anatomical weakness. We all know the presence of anatomical weakness is going to be your Killian's Day cells or the Killian's triangle, right? So when you talk about the Killian's triangle, we all know the boundary. The Killian's triangle, it is going to be having an upper oblique thyropharyngeus. It is an oblique thyropharyngeus muscle. And then you have the lower transverse cricopharyngeus. It is the cricopharyngeus muscle. Between these two, you have the Killian's Day cells, right? Now, obviously, the third important is going to be the trigger factor, which is hard swallows. Now, Zenker's diverticulum is more common in males when compared to females, usually seen in age above 50 years. What is the complaining presentation? Remember, the most important is regurgitation of previous day food particles. So there is regurgitation of previous day food particle. Regurgitation of previous day food particle, halitosis, and intermittent dysphagia. Three findings. All these are important to make a diagnosis of Zenker's diverticulum. So intermittent dysphagia is noticed. For all diverticular disorders, the investigation of choice is going to be barium swallow. So in the barium swallow, you can see there is pouch-filled barium. There's a finding, you can see the pouches filled with barium. It is called as pouch-filled barium is present. We call this as the pouch-filled barium. Now, on the other hand, in terms of management, remember if the diverticular segment, if it is more than 3 centimeters in diameter, if the diverticulum length is more than 3 centimeters, then I would do an endoscopic Dolman surgery. Do a endoscopic Dolman's surgery where we are removing the septa, right? If it is less than 3 centimeters, then you have to go with diverticulectomy with primary repair. Less than 3 centimeters in length, so you have to do a diverticulostomy with primary repair. Okay. It's a diverticulostomy with primary repair. That's it. So this is in terms of your Zenker's diverticulum. Now your radiological spot test. Now this is your time to tell me what you're able to see. What is image number one? The image number one is your coiling of nasogastric tube that is seen in tracheoesophageal fistula. Okay, what is your spotter number three? Spotter number two, sorry. Spotter number two is nothing but upper esophageal web. Where do you see this upper esophageal web? In which condition do you see the upper esophageal web? It is seen in Plummer-Vinson syndrome. This is seen in the Plummer-Vinson syndrome, or also commonly called as, what is the other name for Plummer-Vinson syndrome? It is also called as the Patterson-Kelly syndrome. It is also referred to as the Patterson-Kelly syndrome. The image number 3 is going to be your lower esophageal web. It is going to be your lower esophageal web. And this lower esophageal web is your Schatzki's ring. The lower esophageal web is what we call it as the Schatzki's ring. This is what we call it as the Schatzki's. It is the Schatzki's ring secondary to GRD. Image number 4, this is what we call it as the apple core sign. There is an apple core sign, also referred to as your shouldering sign in the esophagus. Both these spotters indicates towards esophageal carcinoma. It is your esophageal cancer. Then you see pouch-filled barium. There is a pouch-filled barium in the cervical esophagus. In the cervical esophagus gives you a diagnosis of the Zenker's diverticulum. Next, you have a massive air bubble in the left hemithorax. So this massive air bubble in the left hemithorax, massive air bubble in left hemithorax. There is presence of pulmonary hypoplasia. There's left-sided pulmonary hypoplasia. And then you have dextrocardia. Then you have the dextrocardia. All these points towards Bosch-Dallab hernia. Now, the last one that you have, it is your red velvety mucosa. The red velvety mucosa that you see on an upper GI endoscopy is the characteristic features of your Barrett's esophagus. It is the Barrett's esophagus. Okay. So these are all the important spotters in the esophagus. All of them are important from the image perspective as well. Okay. So we'll roll across into the stomach. So we'll have to go through the stomach. A couple of important topics are there in the stomach. Slightly extensive is that. Then you have intestines. Okay. Okay. Now we talk about the pathogenesis of the congenital hypertrophic pylorostenosis. The pathogenesis is going to be because of, it is idiopathic. It is idiopathic hypertrophy of circular muscles. It is the idiopathic hypertrophy of the circular muscles, and that too at the pyloric region. At the pyloric region, causing gastric outlet obstruction. Causing a gastric outlet obstruction. Now, the clinical feature would be of gastric outlet obstruction. First important thing, you will notice that the age of the child is going to be between 3rd to 6th week. Single best answer is going to be 4th week. It is more common in a male child when compared to female, especially in the first born male child. Firstly, most important is in the first born male child. Now, when you talk about the clinical features, number 1, there'll be repeated episodes of vomiting. This repeated episodes of vomiting will be non-bilious and projectile in nature. It will be non-bilious and projectile in nature. That's the presentation that you have. Now, on examination, there is presence of olive lump, visible peristalsis, and scaphoid abdomen. Scaphoid abdomen is seen post vomiting. The fourth finding that you'll see is presence of abdominal pain. How do you know there's an abdominal pain? You will see when the baby is crying, the hands are flexed. The hands are going to go into flexion and extension. The limbs are going to remain only in a flexed state. What is the electrolyte imbalance that you're going to expect? Now, in an electrolyte imbalance, to understand, we all know that whenever the baby is going to vomit, the gastric content, that is hydrochloric acid and water, is going to go out. Wherever water goes, sodium follows. So if you split them into ions, this is proton, this is chloride, water is not important. Again, the elemental sodium is lost. So loss of protons will result in metabolic alkylosis. Loss of chloride will result in hypochloremia. Sodium is the most cherished element. In order to preserve sodium, renin, angiotensin, aldosterone will kick in. Now, RAS system, in order to conserve sodium, it will start loading potassium. So it will result in hypokalemia. And for every sodium that has to be saved, a proton has to be excreted into the collecting duct. So the proton's concentration in the urine will increase. Already body is losing proton, it should conserve, but in order to conserve sodium, it is losing protons. Hence it is called as paradoxical aciduria. This is paradoxical aciduria, right? Now, in order to evaluate, the first investigation here is going to be an X-ray. And X-ray, you will see there is presence of a massive single bubble sign. There is presence of this massive single bubble sign is noticed. There is this massive single bubble sign is noticed. Investigation of choice is going to be ultrasound. In the ultrasound, it looks like a cervix ultrasound. So it is also called as the cervix sign. Now, when you look at closely at the image, you see this projection which is present, which is called as the antral nipple sign. This is what we call it as the antral nipple sign. Now, we all know the characteristic marking that you need to know. In order to call this, the length of this and the width of this has to be measured. Remember, if the length of this hypertrophy segment is more than or equal to 16 millimeters and the width is more than or equal to 4 millimeters, it is characteristic of congenital hypertrophic pylorostenosis. The management is going to be surgery. The surgery of choice is going to be Ramsted's pyloromyotomy. Now, one of the most repeatedly asked exam question is going to be on neonatal vomiting. Now, in the neonatal vomiting, this is how you'll have. If you have a baby who is 4 weeks old and baby presents to you with vomiting, which is, let's say, considered to be non-bilious. Let's say this is a non-bilious vomiting and it is projectile in nature. And you see on the image, there is presence of single bubble. There is presence of single bubble sign. The diagnosis here is going to be congenital hypertrophic pylorostenosis. Management is going to be your Ramsted's pyloromyotomy. We just learned the answer, right? Now, on the other hand, day 0, day 1 of life, let's say baby presents to you with bilious vomiting, which is non-projectile. And on X-ray, you can see the two bubbles. One is your gastric bubble, another one is duodenal bubble. This is what we call it as the double bubble sign. Now, double bubble sign is seen in two conditions. One is going to be your duodenal atresia. And one more is going to be your annular pancreas. It can be your annular pancreas. Management is going to be for both of them duodenostomy. It is going to be duodenostomy, right? Again, day 0 and day 1. Again, you have day 0, day 1. Baby presents to you with bilious vomiting. It will also remain non-projectile. But on X-ray, I see that 3 bubbles. There's gastric bubble, there's duodenal bubble, and a jejunal bubble. So this is what we call it as the triple bubble site. This is what we call it as the triple bubble sign. And triple bubble sign is seen in a condition that is called as the jejunal atresia. It is called as the jejunal atresia. So management here is jejunostomy. It is going to be your jejunostomy. It is your jejunostomy. So these are the context of recurrent vomiting. So if there's a question on your neonatal vomiting, no question you'll be able to miss if you understand this chart. Clear? Sorted? So moving on, peptic ulcer disease, again a very, very important topic. Oh. Right. Let's talk about the duodenal and the gastric ulcer. The most common site for duodenal ulcer is the first part of duodenum. Gastric is going to be angularis incisura. It is going to be your angularis incisura. Ulcer environment in the duodenal ulcer is going to be hyperacidic, as there is metaplasia into gastric type of mucosa. Here it can be normoacidic or it could be hypoacidic. Right? The pain is present in both duodenal and gastric ulcer, but duodenal ulcer has more pain when gastric ulcer has more pain when compared to duodenal ulcer. So here, remember, it is after 2 to 3 hours of consuming food. Here it is immediately on consuming food. It is immediately after consuming food. Right. Now, appetite, because there is after 2 hours of consuming food increases, food pain will cause significant decrease. Here, there'll be presence of weight gain. Here, the patient will have weight loss. Risk for hemorrhage is present in both. Risk for perforation is also present in both. Remember, it is usually the anterior ulcers that perforate and the posterior ulcer that is going to be bleeding. Remember, duodenal ulcers can never be pre-malignant. It is the gastric ulcers which are usually pre-malignant. For duodenal ulcer, investigation is upper GI endoscopy. Here, upper GI endoscopy with biopsy has to be performed because it increases the risk for adenocarcinoma of the stomach. If you're looking for H. pylori assessment, remember it is the urease assay test, which is the investigation of choice. The best is going to be culture. Breath urease test is to assess the response to treatment. To assess the response to treatment, the breath urease test is done. Stool antigen is the most cost-effective test. It is the most cost-effective tester. The precaution is PPI must be stopped 2 weeks prior the investigation, and antibiotics must be stopped 4 weeks prior to the investigation. Okay? So these are the basic objectives that you have to consider. Now, we have two contexts of therapy. One is your triple therapy, another one is quadruple therapy. The only difference is they will have PPI to decrease the acid, clarithromycin and amoxicillin metronidazole is going to be for countering your H. pylori. In the quadruple therapy, we are going to add bismuth or sucralfate, which is going to be ulcer protective. That's it that you need to know with respect to peptic ulcer disease, right? Now, in terms of gastric carcinoma, the risk factors we have listed, but before we move on, the most common site, it is going to be the proximal stomach. It is going to be the proximal stomach, and the most common type, it is going to be the adenocarcinoma of the stomach. It is going to be the adenocarcinoma of the stomach. Now, you have following risk factors: nutritional, environmental, medical, and others. Remember, the most important for you to recognize here, the most important to recognize Number one is low fat and the protein consumption, salted meat, and obesity. Environmental factor, all these poor refrigeration, all these will cause H. pylori infestation. So here the basic concept is H. pylori. Medical, remember all your previous gastric surgeries, H. pylori or an Epstein-Barr virus infection, history of radiation exposure, atrophic gastritis, and presence of adenomatous polyps. All these are the medical risk factors which are going to be present. And others may male sex and low socio-economic status. These are the important aspects that you need to remember, right? Now, in the gastric carcinoma, we have a classification called as Lawrence classification. This was your NEET PG question, very possibly could be asked in our exam as well. Now, according to Lawrence classification, we divide the gastric cancers into two varieties, the intestinal and diffuse variety. Remember, intestinal variety is more common in males. Diffuse variety is more common in females. The age of presentation of intestinal variety is seen above 50 years, whereas diffuse is relatively in a younger age group. Remember, intestinal variety is not familial. Diffuse variety is familial. The genes which are associated with this is APC gene P53 and P16, whereas for diffuse variety, it is E-cadherin P53 and the P16 mutation. What are the important risk factors here? It is associated with gastric atrophy. It is associated with gastric atrophy. Here it is associated with blood group A. It will be associated blood group A. Other risk factors that you have is presence of intestinal metaplasia. It is the intestinal metaplasia. Now, when I say the mode of spread, it is going to be hematogenous for intestinal variety, direct and lymphatic spread is for diffuse variety. HE on histology, you will see a gland forming variety. It is going to be a gland forming variety. Here, on the other hand, it is going to be of signet ring variety. In the entire GIT, if you find signet ring variety, it is associated with poor prognosis, and this is associated with relatively good prognosis. This is associated with relatively good prognosis. This is your Lawrence classification. Now, when we talk about the clinical presentation, nothing great about the clinical presentation, but you will see classical features. It will be associated with abdominal pain. Along with the pain, there will be repeated vomiting, telling you it is a feature of gastric outlet obstruction. It's a feature of gastric outlet obstruction. Apart from that, if it's a proximal malignancy, it will be associated with dysphagia and dyspepsia, right? Along with that, it can associate with significant weight loss. It can have significant weight loss and upper GI bleed manifestation. These are the common presentation, but we are more interested in the atypical presentation. Now, enlarged left supraclavicular group of lymph nodes, it is what we call it as the Virchow group of lymph nodes. It is the Virchow group of lymph nodes, and this is what we call it as the Trozier sign. This is what we call it as the Trozier sign. Irish group of lymph nodes, these are your enlarged left axillary group of. It is an enlarged left axillary group of lymph nodes. Sister Mary Joseph group of lymph nodes, it is your enlarged periumbilical group of lymph nodes. It is the enlarged periumbilical group of lymph nodes. Krukenberg's tumor is because of transcelomic. It is a transcelomic spread, that is drop metastasis to ovary. Blummer shelf, it is nothing but a deposit in the rectovesical shelf. Blummer shelf, it is the tumor deposit. It is a tumor deposit in rectovesical pouch. It is in the rectovesical pouch. Notably on the skin, this is what we call it as the lesser prolactin. In the lesser prolactin, you can see presence of multiple seborrheic keratosis. It is presence of multiple seborrheic keratosis. It is the multiple seborrheic keratosis, and this is what we call it as the trypalm sign. This is what we call as trypalm sign. This is hyperkeratotic palm. It is a hyperkeratotic palm. Your scaly palms, you say they become scaled out. If you're not able to appreciate, if I do a zoom in, you can see that scaling of the skin is noticed, right? That is what we call it as hyperkeratotic palm, or also called as trypalm sign. Now, in terms of investigation, remember upper GI endoscopy with biopsy is the investigation of choice for diagnosis. EUS is the investigation of choice for T staging. CT is done for loco-regional spread. PET is the investigation of choice for staging overall. Staging laparoscopy is done to evaluate peritoneal seeding. It is to evaluate peritoneal seeding. That means if the peritoneum is involved by the tumor, it is inoperable status. It is an inoperable status, right? Now, there's a very simple objective with respect to the gastric carcinoma. This is the esophagus. This happens to be stomach. This is the duodenum. This is the gastroesophageal junction. We're going to divide the stomach into the proximal 1/3, the mid body, and the distal 1/3, right? So this is your proximal third. This is your mid body or the middle 1/3, and this is your distal 1/3. So for a proximal 1/3, it has to be total gastrectomy. There's going to be total gastrectomy with Roux-en-Y. With Roux-en-Y esophagogynostomy with D2 lymph node clearance. The same is done for your mid body also, right? So this is the protocol for your proximal and mid body malignancy. Now, for a distal malignancy, for a distal 1/3 of the malignancy, we go with subtotal gastrectomy. Subtotal gastrectomy with Roux-en-Y gastrojejunostomy. With Roux-en-Y gastrojejunostomy. Along with that, there is D2 lymph node clearance. Okay. Post-operative chemo is important. Remember the post-operative chemo that we are going to give. It is going to be ECF. E stands for epirubicin. C stands for cisplatin. And F stands for 5-fluorouracil. F stands for 5-fluorouracil. This is the chemo regime for both esophageal as well as your gastric carcinoma. Both esophageal as well as gastric carcinoma, right? Now, quickly talking about other miscellaneous topics. You have Mallory Weiss tear. Remember, the cause is going to be repeated episodes of vomiting. It is a repeated episodes of vomiting. The most common site for tear, it is going to be the cardia of the stomach. Remember, it is cardia of the stomach. It is a longitudinal tear. It's a longitudinal tear, and it limits to submucosa. It's a submucosal tear. It's a submucosal tear. It will present to you as an upper GI bleed. So the investigation of choice is going to be an upper GI endoscopy. Management if there is presence of an active bleed. If there is presence of an active bleed, then electrocoagulation. If there is no active bleed, if the bleed is absent, then it is self-limiting. Do nothing. It is a self-limiting, do nothing. Now, when you talk about gastric antral vascular ectasia, it is a vascular ectasia in the antrum of the stomach. Remember, it is also referred to as the watermelon stomach. That is your carry home message. Here, patient will present to you with upper GI bleed. Investigation of choice is going to be upper GI endoscopy. Management is going to be electrocoagulation. It is going to be an electrocoagulation. Another one is Delafoy's gastric lesion. It is an abnormal arteriole. Now, this abnormal arteriole is between 1 to 3 millimeters in diameter. The most common site, it is 6 to 10 centimeters on lesser curvature. It is 6 to 10 centimeters on the lesser curvature from the gastroesophageal junction. This also presents to you as upper GI bleed. Investigation of choice is your upper GI endoscopy, and the management is going to be electrocoagulation. The management is going to be electrocoagulation. Okay. So these are about all the upper GI bleeds and the important context that you have to remember. Okay. So that concludes your entire discussion on stomach. So far, any questions, quick feedback? Beta, you will feel the session is very hectic. You feel there is a lot of information going on. You feel the pace is going to be quick, or you feel it is going to be rapid. But let me tell you honestly that this is the only way you will be able to revise entire surgery in a single day. अगर आप पढ़ने बैठोगे 3-4 दिन में भी सर्जरी कंप्लीट नहीं होगी. तो जो सोच रहा है ना कि अभी क्विट कर दूं, होता ये है ना, you're thinking that you want to close your laptop, you want to close your mobile, you want to close your iPad, whatever it is, that occurs because you are lacking that intent. तो अभी एग्जिट नहीं करना है. दोपहर से बैठे हो, शाम हुई है, शाम की रात हो जाएगी, लेकिन इतना याद रख लो कि आज सर्जरी कर लिया तो कर लिया. No, I'm not talking about, see, I do understand as a student. I'm not saying that you're not interested. I'm not telling you that, कि मेरी क्लास इंटरेस्टिंग नहीं है, मेरी क्लास बेस्ट है. That is how I believe it. If I don't believe in that, I'll not be able to deliver that. तो मेरे को उसकी टेंशन नहीं है. मैं एज अ स्टूडेंट पर्सपेक्टिव बता रहा हूँ कि दोज हु आर थिंकिंग ना कि आई एम गेटिंग टायर्ड, अभी घुस नहीं रहा है, अभी बंद कर देते, बाद में रिकॉर्डेड में देख लेंगे, यू आर वेस्टिंग योर टाइम. जो भी है, पुल योर सेल्फ अप. ठीक है, nothing is gonna go wrong if your intent is clear. Exactly. When the going gets tough, the tough gets going. Absolutely correct. बेटा लिखना नहीं है राइट नाउ. इतने प्यार से मैं क्यों लिख रहा हूं? I can scribble. No, I am writing every single word because I know, I understand my students. I want you to go and revise it back. बेटा मेरी राइटिंग समझ में आएगी. You will be able to revise it. कोई टेंशन नहीं लेना. ठीक है. देखो, this is when it all happens, no, कि हमको लगता है कि we might quit. We feel that we are not equipped enough. It is possible. Lekin let me tell you one more important thing. Every time you think, no, that the things are not getting better, that is the thing, that's the exact time when the thing is about to get better. So have that belief and faith. Okay? So let's continue. ज़्यादा नहीं सोचने का. ठीक है. Beta, bore have and Mallory V's are two distinctive scenarios. Mallory V's में patient will only present with upper GI bleed. Bore have syndrome will have macular striae. आगे जाके बताऊंगा क्या है. Sudden severe onset of thoracic pain will be there. there'll be presence of retching and vomiting and cervical subcutaneous emphysema. जब आप एक्सरे करोगे नीमोमीडियास्टर्म देखने को मिलेगा, कॉन्टिन्यूस डायफ्राम साइन देखने को मिलेगा, व्हेन यू ऑस्कल्टेड हेमन क्रंच साइन देखने को मिलेगा, ठीक है। अल्कोहल इज द रीजन फॉर वॉमिटिंग, वॉमिटिंग रिपीटेडली होगा तो मैलरी बेस भी हो सकता है, सडन वॉमिटिस की वजह से विद क्लोज्ड एपिग्लॉटिस कैन रिजल्ट इन बोरहैव सिंड्रोम। तो बोरहैव में स्पॉन्टेनियस इसोफेजियल परफोरेशन देखने को मिलेगा। बेटा वॉमिटिंग इज नॉट, यार ये कौन समझा रहे यार, बेटा वॉमिटिंग इज नॉट द कॉन्सेप्ट, वहां पे वॉमिटिंग इज जस्ट द कॉज। अगर रिपीटेड वॉमिटिंग्स हो रहे हैं एंड द अपर इसोफेजियल स्फिंक्टर इज नॉर्मल, the patient is going to have Mallory there. Whenever he tries to vomit against a closed glottis, that occurs because of acute alcoholism or because of anorexia nervosa. Other components are there with sudden rapid increase in pressure inside the esophageal lumen that will result in esophageal perforation in the lower 1/3 on the posterior aspect of the esophagus. This is your Boerhaave syndrome. Boerhaave में macular striatum देखने को मिलेगा, ठीक है, गलती नहीं करना है। So what is the normal portal pressure? It is going to be 1 to 5 millimeters of mercury. Pre-portal is 6 to 9 millimeters of mercury. Portal hypertension is more than or equal to 10 millimeters of mercury. Bleeding occurs when it is more than or equal to 12 millimeters of mercury. Mortality increases when it is more than or equal to 14 millimeters of mercury. ठीक है। Now, what are the causes for portal hypertension? We all know the first one that I'll talk about is the extrahepatic portal vein cause. So in the extrahepatic portal vein cause, number one is your portal vein thrombosis. It is the portal vein thrombosis. Number two, it is because of portal vein malignant occlusion. It is a portal vein malignant occlusion. Then we talk about intrahepatic portal vein cause. Intrahepatic portal vein cause. For the intrahepatic portal vein cause, it is secondary to schistosomiasis and congenital hepatic fibrosis. And the congenital hepatic fibrosis. When you talk about the hepatic cause, the hepatic cause is your liver cirrhosis. Now, cirrhosis can be because of any reason. And the last one is your post-hepatic cause. Now, the post-hepatic cause is your hepatic vein cause. It can be the Budd-Chiari syndrome or any other form of veno-occlusive disorder. Any other form of the veno-occlusive disorder. As simple as that. So these are the causes for portal hypertension. We all need to remember कि कौन सा post hepatic है, कौन सा intrahepatic है, which is intrahepatic portal vein, which is extrahepatic portal vein. All these causes specifically with respect to their presentation, you all need to remember it. So जब भी portal hypertension होता है, body will try to find an alternate route, and that alternate route is what we call it as the portosystemic collateral. So the first portosystemic collateral that I've listed here is going to be your periumbilical veins. It is going to be the periumbilical vein. The second is going to be the bare area of liver. It is the bare area of liver. The third one will be present with the esophageal veins. The third one will be present with esophageal vein. The fourth one is present with omental veins. The fourth one is with omental veins. The fifth, it is going to be the retroperitoneal veins. It is the retroperitoneal veins. The sixth one, it is going to be the lumbar veins. And the last one, it is going to be with the rectal veins. Now you have also called as hemorrhoidal veins. You have all these varieties that we have spoken. Okay. Only clinically, there are three presents. One is a periumbilical, another one is esophageal, another one is rectal. Periumbilical dilatation will present to you as a caput medusae. It looks like the medusa's hair. Esophageal veins will present to you as bleeding esophageal varices. It will present to you as the bleeding esophageal varices, and the rectal veins will present to you as bleeding hemorrhoids. That is bleeding internal hemorrhoids. It will result in bleeding internal hemorrhoids. Okay. Out of these, the most common clinical presentation is of bleeding esophageal varices. It is going to be of the bleeding esophageal varices. Okay. Now, how would you manage this bleeding esophageal varices? It's a stepwise protocol. The step number one, it is to secure two large IV cannulas. Secure two large IV cannulas and start the patient on IV fluids. Okay. So when you start the patient on IV fluids, the systolic blood pressure should be maintained at more than 80 millimeters of mercury. The pulse rate should be maintained as less than 90 beats per minute. And the hemoglobin should be more than or equal to 8 gram%. If these are not maintained, okay, if this target is not bent, then you have to take the patient for blood transfusion. They take the patient for blood transfusion, right? So you have secured the IV line. You are trying to control the bleed. So in order to control the bleed, what are you going to do? You started with two large IV cannulas, started the patient on IV fluids. We have a target-oriented resuscitations, right? So step number two is basically IV fluid. While you are resuscitating, in order to control the bleed, I will give injection of octreotide. So injection of octreotide, this is the drug of choice for bleeding esophageal varices. After giving octreotide, you will see bleeding is stopped. There is absence of bleeding or it continues to bleed. If it continues to bleed, then I have to do a balloon tamponade. We have already discussed about this balloon tamponade, which is this balloon. This is nothing but your Sandeep Blakemore tube. It is the Sandeep Blakemore tube that will be put across here. So once you do a balloon tamponade, bleeding will come to a halt. Okay. The only precaution is balloon must be deflated. Balloon must be deflated every 12th hourly to prevent pressure necrosis. To prevent pressure necrosis. To prevent the pressure necrosis. Okay. See, these are the targets. No, systolic blood pressure should be more than 80, pulse rate should be maintained less than 90, HP should be maintained more than 8 gram%. These are targets. Okay. Now, once the bleeding comes to a halt, I would like to evaluate from where it is bleeding. So I will go ahead with gastric lavage. Now, the gastric lavage is done with room temperature normal saline. It should be done with room temperature normal saline. Once you have done the lavage, then I will go with the upper GI endoscopy to evaluate and then perform EVL. EVL stands for endoscopic variceal ligation. It is your endoscopic variceal ligation. EVL is your endoscopic variceal ligation. So when you talk about endoscopic variceal ligation, it is basically also commonly referred to as banding. It is referred to as banding, right? Now, after doing an EVL, you send the patient home. If patient presents to you with the first episode of re-bleeding, for these patients, I will perform a repeat endoscopic variceal ligation. Repeat EVL is done. After doing a repeat EBL, if patient presents to you with the second episode of rebleeding, now this indicates it is a refractory variceal bleeding. It is a refractory, the definition is what we call it as. It is the refractory variceal bleeding. So for a patient of refractory variceal bleeding, you have to go ahead with shunt surgery. Shunt that I would like to perform here is going to be TIPS. TIPS का full form है transjugular intrahepatic porto systemic shunt. Transjugular intrahepatic porto systemic shunt. If it rebleeds after shunting, if there is a rebleeding after shunt, then you have to take the patient for liver transplantation. बेटा इसमें क्वेश्चन ऐसे आएगा कि व्हाट इज द ड्रग ऑफ चॉइस टू कंट्रोल द ब्लीडिंग इन ब्लीडिंग एसोफेजियल वायरसेस? ऑक्टेओटाइड है। लवाज जब कर रहे हो कौन सा फ्लूइड यूज करोगे, क्या टेम्परेचर है? अपर जीआई एंडोस्कोपी क्यों करते हैं? टू लोकलाइज एंड डू एन ईवीएल। कब आप रिपीट ईवीएल करोगे, कब आप शंट सर्जरी करोगे, उसका क्राइटेरिया दिया हुआ है। दिस इज हाउ द एग्जाम क्वेश्चन इज गोइंग टू बी आस्क्ड। ठीक है, सो दिस विद रिस्पेक्ट टू मैनेजमेंट ऑफ ब्लीडिंग esophageal varices. ठीक, now in terms of intestine, now in terms of intestine, we'll talk about Meckel's diverticulum. Meckel's diverticulum is nothing but remnant of vitalo-intestinal duct. As most of you know that this is the representation of yolk sac. This is your vitalo-intestinal duct, and this is the bowel that is there. A remnant of vitalo-intestinal duct is what will result in development of Meckel's diverticulum. Remember, Meckel's diverticulum is an example of a true diverticulum. It is an example of a true diverticulum, right? Now, this will be present on the anti-mesenteric border. This will be present on an anti-mesenteric border. Okay. So the rule of two, which is there, remember it is seen in 2% of the population. So hence this is the most common congenital disorder of the small intestine. This is the most common congenital disorder of small intestine. Now it is basically 2-inch in size. It is going to be 2 feet, approximately 60 centimeters, proximal to ileocecal junction, that is IC junction. It is 2 feet proximal to IC junction. It has got 2 different mucosa. It has got 2 different mucosa. One is your ectopic gastric mucosa. Another one is an ectopic pancreatic tissue. An ectopic pancreatic tissue. Okay. Now, what are the complications? It can occur as bleeding, present to you as massive lower GI bleed. Now, this massive lower GI bleed secondary to peptic ulcer disease, and that peptic ulcer disease occurs because of gastric mucosa, which is ectopic. The most common source, it is going to be the ileopolic artery. It is the ileopolic artery, it's a branch of superior mesenteric artery. Obstruction, it occurs because of intersusception. It occurs because of intersusception. Meckel's diverticulum acts as a lead pointer. In fact, Meckel's diverticulum is the most common lead point in children. It is the most common lead point in children. In diverticulitis, a patient is going to present to you with right iliac fossa pain. They will have right iliac fossa tenderness. Patient is going to have fever. Because of irritation of the bowel, it will have nausea as well as vomiting is noticed. So there is presence of pain, fever, tenderness, nausea, vomiting. And when you look at the CBC, there'll be leukocytosis. Now, all these points towards appendicitis. So the most common differential diagnosis for this is acute appendicitis. It is going to be your acute appendicitis. Okay? It is going to be acute appendicitis. Yeah. So this is with respect to the complications in respect to bleeding, obstruction, as well as diverticulitis. It's a diverticulitis. Now, when I say what is the investigation of choice, this is going to be your technetium 99 scan, which has got high affinity. It has got high affinity for gastric type of mucosa. And bladder type of mucosa. And the blood type of mucosa. Management is going to be diverticulectomy with primary anastomosis. With primary anastomosis. If the most so most of the Meckel's diverticulum, it is your neuroendocrine. So what is the current indication for first age less than 50, male sex, diverticular more than 2 centimeters, presence of abnormality. If any one is present, this is an. Okay, so this is about your Meckel's diverticulum. So, for any questions, guys, quick feedback. Somebody complaining about lag? Any lag? Wow. Video is getting stuck. Not bearable. Guys, I'm taking the lecture from our Arise studio only. Internet is usually good here, but I don't know what's happening. Let me find somebody. Problem happens for all the lectures. Now it's good, it's better, it's okay, fine now. The internet connection is keep on dropping. Give me 1 second. The problem is I speak a little bit slow, no? Probably you'll get a better percent. But the thing is, if you start making it slow, okay? Chalo. So to talk about action, we have intersusception versus volvulus. Intersusception is basically nothing but when the proximal end of the bowel telescopes into the distal end. This is the proximal end, this is the distal end. It is defined as the proximal end of the bowel telescopes into distal end. Into distal end. This is interception. Volvulus is the loop of intestine. If the loop of intestine rotates around its own axis. If it rotates around its own axis, right? Now, if I say what is the most common site of interception in children? In children, remember it is iliopolic. If I change the most common site in adult, the most common site in adult, it is going to be colopolic. It is going to be colopolic. It is going to be colopolic. On the other hand, when you look at the volvulus, the most common site for volvulus, it is going to be your sigmoid colon. And the most common type, it is going to be anti-clockwise rotation. Anti-clockwise rotation. Okay. One second, guys. Okay. So this is with respect to, right? So in the interception, we all know what are the present. अच्छा, in terms of lead point अगर पूछ लेगा ना, इतना याद रखना, most common lead point in children, most common lead point in less than 1 year age, it is hypertrophized Peyer's patches. It is your hypertrophized Peyer's patches. Okay. If I say most common lead point in children, we have just learned it is your Meckel's diverticulum. Most common lead point in adult. Most common lead point in adult, it is going to be polyps. It is going to be polyps. Okay. Sure. Correct. So when you look at the presentation, here it will have small intestinal dynamic obstruction. It will have small intestinal dynamic obstruction. It is a small intestinal dynamic obstruction that is present. Okay. Now, when a patient is present with small intestinal dynamic obstruction, you want to evaluate it. Remember the investigation of choice for interception in children. It is going to be ultrasound. Investigation of choice in adult, it is going to be CT. But when you do a barium enema, which is there as an image, you see a classical claw sign. You see, this is the claw sign where you see the bowel has looped inside. So in an ultrasound, you see this is what we call it as the target sign. So on an ultrasound, you will see presence of target sign. Whereas in volvulus, it will present to you as large intestine dynamic obstruction. It will have feature of large intestinal dynamic obstruction. When you do an X-ray, in an X-ray, you will see presence of coffee bean sign. It's a coffee bean sign. The investigation of choice is going to be a CT only. But when you do a barium enema, you feel as the bird is waiting to catch its prey. And this is what we call it as the bird of prey sign. This is what we call it as the bird of prey sign. This is what we call it as the bird of prey sign. Okay. Now, management for interception, the first line management is to start the patient on enema for resolution. The first line, it is going to be enema. Now, in enema, we'll start with air followed by barium. If not, then you will go with exploratory laparotomy. We do an exploratory laparotomy to reduce intersusception. To reduce intersusception. Here, the first line management is going to be colonoscopic detorsion. It is to be colonoscopic detorsion. If does not work, then again take the patient for exploratory laparotomy. Exploratory laparotomy and then do a detorsion of volvulus. From here, you decide whether it is going to be viable, non-viable. Viable है, do a diversion colostomy. Non-viable है, do a Hartmann's procedure. Okay. So after you've done a detorsion, you will see the bowel. If it is viable, then you will do a diversion colostomy. If it is non-viable, then you do a Hartmann's surgery. Then you perform a Hartmann's surgery. Okay. So this is in context. This is in context of your both volvulus as well as intersusception. Okay. Now, very important topic, your inflammatory bowel disease. It is going to be your inflammatory bowel disease. Now, in the inflammatory bowel disease, we have the option that is your Crohn's as well as ulcerative colitis. A quick recap on both. The age of presentation in Crohn's will be the first peak is 20 to 30 years. The next peak is going to be 50 to 60 years. Bimodal presentation. The same is going to be for your ulcerative colitis as well. So the first peak is going to be between 20 to 30. The second peak is going to be between 50 to 60 years. Crohn's is more common in Crohn's sounds like crown. Crown is usually worn by females. It is more common in females when compared to males. Ulcerative colitis. So it is like, it look like it's a very authoritative word. So sounds more common in males when compared to females. What is the major risk factor here? It is smoking. Ulcerative colitis is an autoimmune disorder. I'm so sorry I have to take this call. This is important. 1 second. Right. So what is protective for Crohn's disease? Remember, there's nothing protective for Crohn's, but smoking is considered to be protective for ulcerative colitis. The two genes, that is your NOD2 and CARD15, are the genes which are associated with Crohn's. So there's no gene association with ulcerative colitis. Remember, site involved here is all the way from the oral cavity to anal canal. But if I say what is the most common site, the most common site is going to be terminal ileum. Ulcerative colitis will only involve the large intestine. And if I say the most common site for ulcerative colitis, it is going to be rectum. It is going to be rectum. Okay. Now, clinical presentation is going to be almost same, but what you have to remember is in Crohn's, there is transmural. That means the entire thickness of the bowel wall is involved. Here, it is going to be involvement of mucosa and submucosa. So there is mucosa and submucosal involvement that is seen across here. So when we talk about the transmural involvement, what are the components here? So because the inflammatory bowel disease, because of inflammation, there will be rubercular tumor, same features in the bowel will be there. So patient is going to present to you with diarrhea associated with abdominal pain. There will be diarrhea, which is associated with abdominal pain. Along with that, because of transmural involvement, it can result in stricture, causing obstructive feature. It can also cause internal fistulas. And because it is involving terminal ileum most commonly, it can also be a differential diagnosis for acute appendicitis. It can also be a differential diagnosis for acute appendicitis. Here, patient will have diarrhea, will have abdominal pain. And another feature, there'll be hematochezia because it is in rectum. So fresh blood in stools are noticed. It is going to be fresh blood in stools are going to be noticed. Okay? Now, remember the presence of skip lesions in Crohn's disease. Ulcerative colitis will have a continuous lesion. It will have a continuous lesion. Now, in the radiological assessment, you have Crohn's will have string sign of Cantor. That thinning I have marked with the arrow, and here you will have a classical lead pipe appearance. There is a loss of colonic frustrations, which will give you a classical lead pipe-like appearance. It will have a classical lead pipe appearance, right? So this is the clinical presentation that you will see in your inflammatory bowel disease. Okay? Now, when you talk about the gross appearance on the Crohn's, this is what we call it as the cobblestone mucosa. This is what you have the cobblestone mucosa, and this is what we call it as the bear claw sign. As if a bear has taken the claw and completely spread across. This is your mesenteric fat creeping. Mesenteric fat creeping. And this is the stricture. So a transmural stricture. So it's a transmural stricture that is present. Okay. So all these signify the Crohn's disease. Ulcerative colitis, it will have a continuous lesion. And if I zoom it across, you will see these. These are nothing but pseudo polyps, right? Called as the inflammatory polyps. They are called as the inflammatory polyps, or also referred to as pseudo polyp. Also referred as pseudo polyp, right? Now, when you talk about the extra intestinal manifestations, it will be associated with erythema. I'm writing the most important ones: erythema nodosum and pyoderma gangrenosum. And the pyoderma gangrenosum. It is erythema nodosum as well as pyoderma gangrenosum. Whereas when you talk about the extra-intestinal manifestation, it is going to be sacroileitis. It is going to be sacroileitis and primary sclerosing cholangitis. And the primary sclerosing cholangitis. Crohn's, it is only going to be medical management. We'll start the patient on steroids, which is the mainstay. Along with that, azithromycin, and infliximab. The same will be done for ulcerative colitis, but if it fails, the second line is going to be surgery. and the surgery of choice is going to be total proctal colectomy with ileoanal J pouch anastomosis. With a ileoanal J pouch anastomosis. Okay. Yes, the newer drugs are there, but from the surgical standpoint, this is what you have to remember. Yeah. So this is all in all with respect to inflammatory bowel disease. Hereditary cancer syndrome is important. Let's quickly run through. You have FAP, Gardner-Turcot, and Peutz-Jeghers syndrome. Pattern of inheritance for all of them is going to be autosomal dominant. All these disorders are autosomal dominant. Now, the gene which is responsible. So when you look at the gene for FAP, it is your APC gene mutation. Gardner is also APC. Turcot is APC. This is your STK11 gene mutation. The chromosome is going to be chromosome number 5q. This is also 5q. This is also 5q. Peutz-Jeghers syndrome is going to be 19p. That is going to be a 19p. FAP characteristics more than or equal to 100 polyps are present. In Gardner syndrome, the mnemonic to remember that is your forfeit. FAP, osteoma, retinal pigmented epithelium. It is your retinal pigmented epithelium. F stands for fibroma, epidermal cyst, and desmoid tumor. Turcot syndrome is a combination of FAP with brain tumors. It is FAP with brain tumors. They are usually glioma as well as medulloblastoma. It is the glioma and the medulloblastoma. और APC APC लिखा है, एक जगह ACP लिखा. ठीक है. Peutz-Jeghers syndrome is a condition which is associated with polyposis, multiple polyps. Most commonly, it is hamartomas polyp. And the most common site of this is going to be jejunum. Polyposis with mucocutaneous pigmentation. It is the mucocutaneous pigmentation. FAP के लिए most common site rectum है. The most common site is going to be rectum. Okay. So how do you manage FAP? Remember FAP का जो management है total proctal colectomy with ileoanal J pouch anastomosis. With ileoanal J pouch anastomosis. ठीक है? Sorry. So this is about your hereditary cancer syndrome, right? So okay. Can we take a short break here? My voice is a bit cracking up right now. ठीक है? एक छोटा सा break ले लेते हैं. 15 minutes. We'll resume back. Alright, guys, let's continue. Can we start? Can we start? Quick feedback. Alright. Most common site for the colon cancer. The most common site for the colon cancer is going to be the rectosigmoid. It is going to be rectosigmoid. If you say overall most common, it is rectum, followed by the sigmoid colon. The most common type is going to be the adenocarcinoma. The most common type is going to be, one second. Right, so most common type is going to be adenocarcinoma. Now, when I talk about the various risk factors, now in terms of risk factors, one of the most important is your dietary risk factor. In the dietary risk factor, if there is high fat consumption with low fiber diet, there is going to be low fiber. There is going to be the low fiber diet. It is the low fiber diet. The second important is the genetic component. In the genetic component, it is familial adenomatous polyposis, your Gardner syndrome, your Turcotte syndrome, as well as Lynch syndrome, that is a hereditary non-polyposis colorectal cancer. They are genetic components. Then it is associated with polyps. Remember, the maximum risk for malignancy is with adenomatous. It is the adenomatous sessile villus polyp. It is the adenomatous sessile villus polyps, right? Apart from that, inflammatory bowel disease, the risk is equal for both ulcerative colitis and Crohn's disease. History of pelvic radiation. History of pelvic radiation. All these are going to be the major risk factors for development of your colorectal cancers. Okay? So this is the same risk factors that are going to be there for rectal cancer as well. Going to be for rectal cancer as well. Now, in terms of pathophysiology, remember the normal colonic epithelium is converted to dysplastic with the help of APC gene mutation. From there, it goes into adenoma, and this adenoma transforms into intermediate by KRAS, from there to late by DCC, and finally the malignant transformation by P53. So the question here that you need to address, which gene is responsible for tumor initiation? Now, the tumor initiation is done with the help of APC gene mutation. Which gene is responsible for your tumor progression? Now, with the tumor progression, we have the KRAS mutation and the DCC's mutation, which is responsible for the malignant transformation. Which is responsible for malignant transformation. It is P53 mutation. So three important concepts: tumor initiation by APC gene mutation, tumor progression by KRAS and DCC. Single best answer will be your KRAS, because early adenoma, intermediate adenoma is more important. Malignant transformation is done with the help of P53 gene mutation. Okay? So these are the various genetic components that you need to remember with respect to colon cancer. Now, in terms of the colon cancer, if I divide them into right-sided colonic cancers and the left-sided colonic cancers, morphologically, based upon the morphology, right side you will see more commonly as ulcerated lesions, as well as a cauliflower variety. Whereas when you talk about the morphology, The morphology that is present on the left side, it is going to be tubular variety, which is associated with the stenosing variety. So tubular and the stenosing variety is more common on the left side. It is more common on the left side. Right. Now, right-sided colonic cancer, remember, they will present to you, their presentation will be lower GI bleed manifestation. Whereas here it is going to be presenting to you with obstructive symptoms. Most commonly, it will be presenting to you with obstructive symptoms associated with alteration in bowel habits. With alteration in bowel habits. It is the alteration in bowel habits. Now, we talk about alteration in bowel habits. You have early morning spurious diarrhea. It is early morning spurious diarrhea. There is tenesmus. There is tenesmus. And there is constipation relieving with diarrhea. There is this constipation relieving with diarrhea. There's this constipation that is relieving with diarrhea, right? So you have early morning spurious diarrhea, tenesmus, and the constipation that is relieving with diarrhea are the components that you will see in your left-sided colonic cancer. Now, when you do a barium enema, you will see a very classical presentation, and this is what we call it as apple core sign with colonic hostrations. With colonic hostrations, right? But if I say what is the investigational choice for diagnosis, it is going to be colonoscopic guided biopsy. It is going to be your colonoscopic guided biopsy. If I say what is the tumor marker, it is the CEA that is elevated. Remember, you can have multiple lesions at the same time, which are called a synchronous lesion. The probability of the colonic cancers to be having a synchronous lesion is 3%. It is going to be 3%, right? On the other hand, if I say what is the investigation of choice for staging, the investigation of choice for staging is going to be PET-CT. The most common route of spread for colonic cancers is going to be hematogenous, and the most common site for secondaries, it is going to be liver. For all entire GI malignancies, because of portal circulation, it will land up in liver alone. So you need to remember the Duke staging, where we talk about Duke staging A, it is going to be tumor which is confined between mucosa and submucosa. Tumor which is between mucosa and submucosa, it is Duke stage A. So between submucosa and serosa, it is B1. B2 is beyond serosa, that is serosal